Good evening, dear students. Today's session is about the important topics in anatomy, the one-liners, and it is basically targeting the exam INI-CET in the month of May this year. Now, since there are 100 lines which I have to take care of, it is understood that even if we take one line per minute, 60 plus 40, so 1 hour 40 minutes. So, this session will last about 2 hours. We are starting at 5, so till 7 we will try to wind up, because obviously you should be spending more time with you in self study rather than with us, but maybe it will help give you a final touch. So, as I see Ladla, Shri, Radha, Ranika, Kshitiz, Vikas, Manshre, Pooja, Alex, good evening. Namaskar, Rishikesh, Bhavna. So, as we start, the very first question which you find in front of your eyes is about the embryology section, conotruncal septum develops from. Conotruncal septum is the other name of aorta pulmonary septum in the developing heart, which will be dividing the truncus arteriosus into two parts, aorta and pulmonary trunk. So, the question, as you see, is asking us about the origin, embryological origin, and conotruncal septum should be developing from. Let me see. Yes, you already have answered. Neural crest cells, perfect. Now, as you say, it is the neural crest cells. Sometime there may be a problem with neural crest cell migration in the head neck region and proximal vessels of the aorta, DiGeorge syndrome. And DiGeorge syndrome is a problem of neural crest cell migration basically. If we have a case of neural crest cell migration problem, that is the DiGeorge syndrome, it is understood that we can have what is called as conotruncal septum anomalies. And these conotruncal septum anomalies could be persistent truncus arteriosus, or it could be the transposition of great vessels, or it could be tetralogy of Fallot. And it is also to be understood that neural crest cell migration problem, DiGeorge syndrome, the most common cause of death is cardiovascular defects, and that could be basically conotruncal septum anomalies. Okay, so let us look at some of the questions which belong to histology, because recently we have seen a lot of histology questions keep appearing in INI-CET exam and All India PG exam. So, what do you think is the answer to this question? It is asking us about the brush bordered epithelium. So, brush bordered cuboidal epithelium in which part of nephron? What do you think? Yes, you already have answered, proximal convoluted tubule. But the problem is that the examiners these days give you histological slides and you should be able to identify the PCT. How do you identify PCT in the slide? Yes, your answer is brush bordered cuboidal epithelium is seen in proximal convoluted tubule, which is a part of the nephron. But how to identify that? Yes, it increases the surface area, that is correct. So, as you see, this is one slide which you should be able to identify, and let us say in this slide you find these are some of the questions which have come very recently in the last 5 years basically. So, we are going to target them repetitively, and in this histological slide what you notice is, see, this is a bunch of cell, cluster of cells which will be mesangial cells and the capillaries, the glomerulus. So, here this is the glomerulus, the mesangial cells, and around that you can see there is a space also where the urine will be formed, and we can call it as the renal space or urinary space. So, this is kidney having glomerulus. Now, around the glomerulus you will have PCT and DCT, there are some sections. So, we have magnified one of the glomerulus and the section of PCT DCT, and you will find that again the same thing we repeat. This is the renal space where the urine will be formed, which is basically ultrafiltrate of blood. And inside here you will have the messenger cells, the capillary cells, the endothelial cells giving ultrafiltrate of blood, which is urine in the renal space. But where is PCT and DCT? If this is the glomerulus, where is PCT and DCT? So to identify that, you can see here, this is one specimen where you see spherical, round spherical nuclei, and the lumen is bit hazy. It is hazy. That is hazy because lot of microvilli are there, brush bordered epithelium. So this is a diagram where we can comment upon the name. This is a PCT. Now how do you identify PCT versus DCT? This is one of the DCT here, and you will see the lumen is larger and clear because the DCT cells, they are also cuboidal cells, but their microvilli are very few, they are not brush bordered. So again you see this is the lumen of DCT, again spherical, central spherical nuclei, but there is a difference. In PCT they are cuboidal cells, in DCT they are low cuboidal cells. They are cuboidal, but there will be height will be lesser compared with the PCT. So here this is DCT, identified by one more fact that around the glomerulus you will have more of PCT and less of DCT. So if you look for DCT kind of thing, there will be few, and the PCT there will be more, plus the lumen is hazy. If you want to see the lumen again, I can rub it off and you can see the difference that in the PCT the lumen is hazy because of those brush border as compared to DCT. Now you can see in DCT there is a modification towards the glomerulus. The cells, they have become quite crowded and they are called as macula densa, and we are talking about juxtaglomerular apparatus. So the DCT towards the afferent arteriole coming into the glomerulus, you will find there is dense arrangement of the cuboidal cells and they have become dense, macula densa. And what is the use of this juxtaglomerular apparatus? It is basically to control the glomerular filtration rate, the GFR. With that overview, as we move further, you will notice that this question already, these are all repeat questions. Basically I have modified them slightly. So what do you think the answer could be here? Juxtaglomerular apparatus is related with the junction of, related at junction of in the nephron. Basically we are talking about nephron, parts of nephron, and where exactly is this JGA? Obviously we said it is modification of the DCT cells, the cuboidal cells of DCT becoming macula densa, but then it is asking what exactly is the junction. There should be a junction point, two parts of nephron. So as you are mentioning TL DCT, right. So for that purpose, yes, of course, thick ascending limb of the loop of Henle, and then you have distal convoluted tubule. So you are perfectly correct that it is junction of thick ascending limb of the Henle's loop and the distal convoluted tubule. This is basically again low cuboidal cells. So these are low cuboidal cells, but that low cuboidal cells will continue even into the DCT. DCT also has low cuboidal cells as compared with the normal cuboidal cells in the PCT. Point is that if this is a normal cuboidal cell in PCT, then if you look at the thick ascending limb of loop of Henle, or if you look at the DCT, cells will be similar but little bit of a shorter size. You can look at the height of this cell. So low cuboidal, maybe it is DCT or it is thick ascending limb of loop of Henle. You will become aware of all these things once you start practicing MCQs and you understand what is the importance of going into so much of detail. But anyhow, because I believe by this time you would already have practiced a lot of questions, so I should not repeat this, that the practice of previous year question is of paramount importance. Now As you see, this is the glomerulus, and one vessel is coming. Let us say this is the afferent arteriole, this is the glomerulus. From there, the urine, ultrafiltered blood, will be entering into what is called as, say, the PCT. This is proximal convoluted tubule now, and this proximal convoluted tubule becomes the loop of Henle. This is the loop of Henle. In loop of Henle, there will be a thin loop, and there is a thick ascending limb of loop of Henle. So here you see this is thick ascending limb of loop of Henle, and as it is meeting with the DCT, this is the distal convoluted tubule. So that is the point or the junction of thick ascending limb of loop of Henle meeting the distal convoluted tubule near the glomerulus, that is a juxta glomerular apparatus. And the purpose of bringing DCT, afferent arteriole, and this glomerulus close to each other is they have some renin, angiotensin, aldosterone system. You know, if there is a less of blood pressure, then increase it, or if there is less of GFR, increase it, or vice versa for that purpose. Okay. So as we proceed further, we have this question. It is asking us, again I'll mention that these are the questions which already would have appeared, and I would have modified them little bit, so that sometimes the questions are repeated, sometimes topics are repeated, sometimes the examiner goes a little bit deeper into the topic. So you must be 1 or 2 steps ahead of the examiner. What do you think is the answer? The contour of lumen is irregular or not smooth in which gland of the skin? First of all, which glands do you see in the skin? In the skin, I will see the sebaceous gland and the sweat gland. And sweat gland is 2 types. One is the merocrine, which is also called acrine, and the other one is the apocrine. So what do you think is the answer? Sweat, yes. Pseudo doctor, fantastic. Happy to know all the information you are giving. Great, wonderful. It's always a pleasure. हिंदी में कहते हैं गुरु दक्षिणा. आपसे हमारे को सिर्फ एक गुरु दक्षिणा चाहिए है, वो ये है कि कामयाब होकर दिखाओ और फिर से कामयाब हो और फिर से कामयाब हो. The more successful you become, and remember us if possible, that is the Guru Dakshina we want. We want nothing else from you. So fantastic. It's always a happy news for us. Okay. See, to deal with such a question, if they are asking the contour of lumen is irregular, I'll take you to the, because these days what they do is they give you some specimens always. So we'll go the same way. Here you notice this is a specimen of skin. How do you know that? I know that because what I find here is this is the hair follicle. Now if this is the hair follicle, you can also notice that we have got the stratified squamous epithelium, which is keratinized. So skin with the hair follicle. Related with the hair follicle, we have this gland here, and that is pouring some sebum along the follicle. So this A should be sebaceous gland. Then there is one more gland which relates with the hair follicle and in the skin, and that will be this marker B, sweat gland. So which kind of sweat gland relates with the hair follicle? See, there are 2 types of sweat glands. One whose duct will directly open onto the skin surface. Mostly it happens like that, but some of these sweat glands, their ducts will open into the vicinity of hair follicle. So as I am suggesting, you can understand that there is one sweat gland whose sweat is coming directly on the surface of the skin. This is merocrine variety of sweat gland, or you can also call it as acrine. So merocrine or acrine. But if you are talking about apocrine sweat gland, if it is apocrine sweat gland, the secretion of this is poured into near the vicinity of the hair follicle. Now magnify it. As you magnify the sweat glands, you can see the difference. The question which we wanted to talk about is becoming evident now. You will notice that if we are looking at the merocrine variety, which is also a crine variety, the lumen is very regular. Lumen is very regular, secretions will be there inside the lumen of the sweat gland. And why? Because only secretions are coming, there is no loss of cell membrane. So lumen is smooth, or it is not irregular, as compared with the apocrine variety of sweat gland. In apocrine variety, apocrine, apical part of the cell is broken, covers the secretion, the sweat basically in this case. So as some part of apical part of the cell is lost, you see, and the pinching of the portion of the cell covering the secretions, you can find the lumen is irregular. You see here, the lumen is not smooth, as smooth, this is smooth lumen here, but there the lumen is not smooth. One more thing, here the lumen is small in merocrine glands, but merocrine sweat gland, but in apocrine sweat gland the lumen is larger. So larger and irregular lumen, apocrine sweat gland. And of course you know how to identify the sebaceous gland. Sebaceous is holocrine, and the whole of the cell is compromised and becomes the secretion, the sebum, and this is one of the hair follicle, as you see near the hair follicle, one of the sebaceous gland, another one, lot of sebaceous glands, they are in the vicinity of the hair follicle and giving the sebum, but holocrine, whole of the cell is broken down and becoming the secretion itself. Here partly some part of the cell is broken down, apical cell membrane, and here no cell membrane is broken down. So lumen here will be smooth and regular as compared with the lumen of apocrine cell, which will be larger and irregular. This was my purpose of showing you this slide, and of course the question was here. As you can notice, you would have understood what will be the answer to this question. So as we see, the contour of lumen is irregular or not smooth in which gland of the skin? And your answer is apocrine variety of sweat gland, apocrine sweat gland. You can simply, if you just want to answer, apocrine sweat gland. Right, let's move on to the next question. Right, yes, some of you already have answered as well. Now as we move further, this is one question which is asking us, now these are all repeat questions as I am telling you again and again. So what do you think is the answer? Perichondrium is absent in. I tried reaching you. See, I am a very lonely person. I don't interact much with people. I am mostly busy with my job, which is to make human anatomy simple. That is what I do. So even my family members, they keep looking for me and I am nowhere to be seen. Either I am in the study room or in the studio. So it's correct, it's very difficult to find me, not because I am a celebrity or something of that sort, no, and also not because I am not a social person. I am very social, but the thing is that I want to spend much of my time into the job which is given to me to teach you better, make you better in anatomy as a physician, as a human. So most of the interactions are usually recorded or live sessions. So I am very sorry, you will find me rarely in social gatherings. Fibrous, okay. Fibrocartilage, yeah, fine, yes, great. So this is one question which is asking us about perichondrium is absent. See, normally perichondrium means, peri means outside, so it is a kind of a capsule of the cartilage and should be present around the cartilage, but is absent in, number one, as you mentioned, fibrocartilage. Fibrocartilage do not have the perichondrium. Number two, it is the articular cartilage. Articular cartilage. Now articular cartilage, most of the time you will find it is made up of hyaline cartilage, but sometimes the articular cartilage could be fibrocartilage, and if it is fibrocartilage, then obviously it will have no perichondrium. Lot of information here. First of all, perichondrium is absent in fibrocartilage and articular cartilage. In articular cartilage, most of the time you will have hyaline cartilage, and some of the places you can have fibrocartilage. For example, articular cartilage of temporomandibular joint is not hyaline, it is fibrocartilage. So one example which you can take here, fibrocartilage working like articular cartilage is, this is the condyle of mandible, and that is the temporal bone. So temporomandibular joint, if you look at their surface, look at the surface of the cartilage lining the condyle of mandible, or cartilage lining the temporal bone. So cartilage lining temporal bone or mandible bone, they are articular cartilage. Articular cartilage is making the surface smooth for smooth movement. It is a synovial joint, freely mobile joint. So the bone must be lined by some smooth cartilage. That is articular cartilage. But that articular cartilage which usually is hyaline is not hyaline in temporomandibular joint, because these bones do not develop in hyaline cartilage, they develop in membrane. They have membranous ossification. So because they have membranous ossification, they don't have hyaline cartilage, and as they don't have hyaline cartilage, instead of hyaline they have fibrocartilage. Fibrocartilage working like articular cartilage is rare. One example is here. Then what is the most common places where we can have articular cartilage as hyaline cartilage? Any joint in the body, say shoulder joint or elbow joint or wrist joint or hip joint, knee joint, any joint, most of the joint which are synovial should have hyaline cartilage. So as you are telling that the hyaline cartilage is mostly working as articular cartilage. For example, this is the, say, humerus bone, the head of humerus. This is head of humerus, and head of humerus is going into glenoid cavity of scapula. So as we say, this is glenoid cavity of the scapula. Now look at the lining cartilage. You will find head of the humerus is lined by articular cartilage to keep it smooth for smooth movement at the shoulder joint, articular cartilage. Similarly, articular cartilage will line the glenoid cavity of the scapula. Now this cartilage which you see here, which is articular cartilage, is which variety? Hyaline. But hyaline cartilage should have perichondrium. If the hyaline cartilage is inside the capsule, if it is intracapsular, here the capsule is the capsule of the shoulder joint. If hyaline cartilage is inside the capsule, then it does not have perichondrium. So question was, perichondrium is absent. Your answer is, perichondrium is normally present in hyaline cartilage, but it is absent in hyaline cartilage if the hyaline cartilage was working like articular cartilage. Now what is the purpose again? What is the purpose of discussing all this? Because I expect the examiner is going into more details. As the exams proceed further, you see the examiner keeps digging the topic deeper and deeper. So love from Kazakhstan, yes, okay, great. My love is for all you students. Of course, again, there are very rare occasions where I can express myself, that kind of attachment which a senior will have with a junior. When we were in MBBS, of course, that attachment was quite evident and we used to enjoy, but these days we are more on screens rather than face to face, and which is in fact a tragedy. We should be interacting more. Let us be hopeful. There will be some live classes this year and I will be conducting some of them if possible. But the workload is quite huge. Maybe the workload is not huge, but I make it huge for myself so that I can give you the best possible. So what do you think? Okay, you identify, these are all cartilages. First of all, tell me in figure A which cartilage is this? B is which type of cartilage, C and D. These are 4 cartilages basically, which already have come as a question, and they gave you the slides, and I am also giving you slides. So can you identify them? First of all, you can see one thing, that there is a perichondrium here. There is a perichondrium. How do you know it is a perichondrium? Because the chondrocytes in the center are quite large, but chondrocyte, the size of chondrocyte become smaller, flatter. Actually they become chondroblast at the periphery. So at the perichondrium, the cartilage cells are not very huge. See, can you see this huge cell, and this cell which has become very small? They are becoming, or in fact it is the chondroblast which becomes chondrocytes. This is chondroblast, and which becomes the chondrocyte. Now this is a perichondrium, one example. Other example of perichondrium is here. Again you can see that perichondrium is at both the periphery. The cells at the perichondrium will be chondroblast, thin cell, but as you go to the center they become larger, and this is also having perichondrium, but that and here they don't have perichondrium. In fact, in this cartilage you can see some bony tissue. This is the bony tissue, and these are chondrocytes. The chondrocytes of different sizes and arrangement. So if you have perichondrium and if the cartilage appears hyalos, glass-like, because the collagen fibers in this cartilage has the same refractive index as the matrix, so merging optical illusion. So hyalons looking hyaline cartilage does have perichondrium. And if you look at this one, you will find the rows of chondrocytes. These are rows of chondrocytes, one chondrocyte running after other, one chondrocyte running after other, and interspersed between them you can find some collagen fibers. So alternate rows of chondrocytes and collagen fibers, chondrocytes and collagen fibers. Too much of fiber, less of chondrocytes, fibrocartilage, and fibrocartilage do not have perichondrium. So this is fibrocartilage, this is hyaline cartilage. What is this? You will see a lot of stuffy fibrous structure is there, and those fibers are basically if you magnify and stain it perfectly, elastic fibers. So if they are elastic fibers, this is how the elastic cartilage will appear. So elastic cartilage will have perichondrium, hyaline cartilage will have perichondrium, but perichondrium will be absent in fibrocartilage and will be absent in the articular cartilage. How do you know it is articular cartilage? I have mentioned that the bone is lying by articular cartilage, and it is kind of a hyaline cartilage. It is kind of a hyaline cartilage. It will also have hyalos appearance, but it will have no perichondrium. So articular cartilage is mostly hyaline cartilage, will have hyalos appearance, but no perichondrium. It will have some subchondral bone. So bone tissue is there because it is lining the bone itself. So this is articular cartilage, doesn't have. So your eyes should be able to identify those. Let me see if you could identify. A is elastic, C is elastic, yes, special stain should be done for elastic cartilage. Then as you are going into more detail, actually this question you should be able to handle. Chondrocytes are arranged in some zones in articular cartilage. We have just seen articular cartilage, mostly it is hyaline cartilage. The matrix and collagen fibers, they merge. So fibers are seen but not very evident in articular cartilage. And how many zones? Actually 3 zones. The answer should be 3 zones. So which 3 zones? I am going into little bit detail. Nobody has asked this question, but I am expecting this question will definitely appear, because this belongs to, of course, anatomy plus orthopedics. Articular cartilage is an important topic in orthopedics also. So this is a diagram which we have taken from Gray's Anatomy basically, and you can look at the details. Let us try to find out some of the details which I want you to remember. See, first of all, it will have the fibers, collagen fibers, but they are not evident. Now, if you say that it has collagen fibers but which are not evident, then what is that called? That is called as the hyalos, or hyaline cartilage. In that also you can see this is subchondral bone. As you can see, calcified subchondral bone. This is subchondral bone. So, bone plus cartilage together, articular cartilage features. Now, 3 zones I told you: the deeper zone, transitional zone intermediate, and superficial zone. So, chondrocytes will be arranged in 3 zones. What is the deeper zone? How do you identify deeper zone? First of all, it is with the bone, and then it is the chondrocytes. As you see, they are actually arranged in a radial fashion. You see, because of the arrangement of the collagen fibers also. So, radially arranged. Now, if you say they are radially arranged in the deeper portion, what about the middle, intermediate portion? In the intermediate portion, they are obliquely present because of the fiber. The fibers themselves arrange the chondrocytes. So, because the fibers are oblique, the chondrocytes will be arranged obliquely. And what about the superficial zone? In the superficial zone, as you see, because of the arrangement of the fibers, the chondrocytes are horizontal. So, superficial or tangential, here the chondrocytes will be in superficial zone, and because of the arrangement of the fibers of the collagen, they are horizontal. Here the oblique arrangement, here the radial arrangement. So, this is something additional which maybe you have never read, but the diagrams which come from standard textbooks, Gray's Anatomy, see, this question has already come. They already have asked you articular cartilage. I have gone a little bit deeper into that. Okay, so let us move on to the next thing here. So, as the question was asking, how many zones are there? And you should tell 3 zones. Okay, fantastic. Right. So, as you move further, you will notice this is one question. It is asking us about the reticular fibers. Quite often repeated question. Reticular fibers are absent in thymus. Now, I have added a little bit more detail. The supporting network is then provided by. If the reticular fibers are absent, see, normally reticular fibers are type 3 collagen fibers, and they form a supporting network on which some of the, see, these are the fibers on which some of the lymphocytes can be sitting. They give a framework for lymphocyte to sit there, kind of a home, making them a home. Now, if thymus is also having lymphocyte, it is a lymphoid organ. If reticular fibers do not form this network, then who is forming? That is a cell. Which cell is that? Can you give me the name? What is the name of these cells which will form the reticular network, which they normally thymus won't have? They don't have type 3 collagen fibers. So, what is the name of cell? Do you know? Sir, can we get the PDF after class? That you will have to communicate with the Prepladder somehow. There are some rules which we have to follow. You can watch this video, it will stay on YouTube. So, you can watch it again, but I really doubt about PDF. I think they have stopped sharing the PDF. Some reasons must be there, some legalities must be there. But the videos remain on YouTube, so you can watch it again. See, they are called as the thymic epithelial reticular cells. Thymic epithelial reticular cells. Let me show those cells, then it will be better. As you notice, this is the normal lymphoid tissue appearance. So, if you look at a lymphoid tissue, you will find that it will have reticular connective tissue, type 3 collagen fibers, and it could be the liver, could be spleen, could be lymph node, could be bone marrow, lymphoid organs, and purpose is provide supporting framework. This is how the reticular fibers appear, and you see a lot of lymphocytes are there. It is making a home for lymphocytes, some special stain there. So, this is absent in thymus. Now, if this is absent in thymus, how do lymphocyte stay there? Who is forming the network? That was the question, and your answer is thymic epithelial reticular cells. So these are the cells we are talking about, and you will notice that these cells, the thymic epithelial reticular cells, these are secreting those fibers, that arrangement. In fact, what they do is, see, one of these cell is making a desmosomal junction with the other cell here. So this is another cell, and then it is making a desmosomal junction with another cell there. So basically they are making a tight junction. Now why they are surrounding the lymphocyte so tightly? They are surrounding them so tightly so that, thymus has one purpose. And what is the purpose of thymus? These are the lymphocytes. So the purpose of thymus is train the lymphocytes, and it is a very meticulous and disciplined trainer, so much so that the cells which reach thymus, 90% of them die during training only 10% survive. So those 10% lymphocyte which survive are given the name thymus dependent lymphocyte, T lymphocytes, and those T lymphocytes are trained for what? They are trained for fighting with the cell mediated immunity. They fight with the antigens like bacteria or protozoa, that is the purpose. So what is the purpose of thymic epithelial reticular cells? They make a framework where the lymphocytes can stay there, because they need a framework basically, and that framework is created by thymic epithelial reticular cells, and they have a purpose. See, they are making tight junction. They will expose the lymphocytes to the antigens in such way that it is not sudden exposure, and it is gradually they expose, and then they train, they teach them how to fight, and that training is so discipline that 90% of the lymphocytes, they die in the process. Only 10% will survive, which will be then given the stamp that, okay, now you are T lymphocyte, you are thymus dependent lymphocyte, and you can go and fight with the bacteria or protozoa and go into circulation now. So then from there they will move into the circulation. Anyway, these thymic epithelial reticular cells, they are derived from which germ layer? They are derived from which germ layer? Can you tell me? Thymus developed from pharyngeal pouch number 3. Pharyngeal pouches are lined by endoderm. So the thymic epithelial reticular cells are derived from endoderm of the pharyngeal pouch number 3, and they may be missing. They may be missing when DiGeorge syndrome. But why in DiGeorge syndrome these cells will be missing? Why thymus will be missing? Because neural crest cells migration problem. Okay, neural crest cell migration problem, but neural crest cell is a separate germ layer. What it has to do with the endoderm of pharyngeal pouches? You have to understand, neural crest cells, they have to migrate and stimulate the endoderm of the pharyngeal pouches. Then only the pharyngeal pouches can form thymus. If neural crests do not come, do not stimulate, endoderm pouches will not form thymus. So first of all, thymic epithelial reticular cells are endodermal in origin. They come from pharyngeal pouch number 3, and they may be missing in DiGeorge syndrome because there was no stimulation by neural crest cells. Now this is going into some more deeper aspect of whatever we are talking about, but that is what the examiner is interested in asking. You should know what the examiner is interested in asking. And how do you know that? By practicing previous year questions. You can always project into future that which kind of questions might be coming next time. That is our job. That should be your job also. In fact, intuition basically. This is what you call intuition. So what was the question? Question was here. It was asking, reticular fibers are absent in thymus, of course. What are the supporting network cells? Thymic epithelial reticular cells, which are endodermal in origin, pharyngeal pouch 3, and might be missing in DiGeorge syndrome. One other thing, Thymus has connective tissue which is derived from secondary mesoderm, which is derived from neural crest cell. That is also a question. So in thymus there are endodermal component, but there are mesodermal component also. So in the thymus, the connective tissue of thymus is derived from. Question was, thymus connective tissue is derived from. The thymus connective tissue is derived from mesoderm. Which mesoderm? Secondary mesoderm. And who is forming secondary mesoderm? That secondary mesoderm is formed by neural crest cell. Neural crest cell forms secondary mesoderm, will form connective tissue of thymus. In fact, most of the head neck mesoderm, especially anterolateral, anterior and lateral mesoderm in the head neck, anterior and lateral mesoderm in the head neck is mostly from neural crest cell derived secondary mesoderm. These bones, where they come from? Hyoid bone, malleus incus stapes, where they come from? They come from neural crest cell derived secondary mesoderm. Pharyngeal arch bones are from neural crest cell derived secondary mesoderm. All are questions. Okay. Now what about this question? It is asking lymphatic nodules with germinal centers not seen in lymphoid organ. So first of all, you name some lymphoid organs. Lymphoid organs we just mentioned could be the tonsil, or could be the lymph node, or it could be the spleen, or it could be the thymus. We just mentioned thymus is typical because it does not have this reticular fibers. Now if you already have mentioned these names, lymphatic nodule with germinal center. What is lymphatic nodule with germinal center? There will be a lymphatic nodule and there will be some cells. So there will be a germinal center because there are some lymphoblast. So there are some lymphoblasts in the germinal center, and then there are some lymphocytes which are in the periphery. Germinal center is slightly paler as compared with the dark periphery. So this is pale, this appears a bit pale, and the germinal center, and periphery will be a bit darker. And this kind of appearance is because a lot of lymphocytes are there. Lymphatic nodule, which is also called lymphoid follicle. So lymphatic nodule, lymphoid follicle are definitely features of lymphoid organ, but where are they absent? And again your answer is, as you will notice, your answer to this question is thymus. Thymus do not have the lymphatic nodule. So you mean to say you have a lymphatic nodule in tonsil, lymph node and spleen? Yes. Let us look at one diagram. But here your answer should be thymus. Okay. So where are the details? You see, this is one diagram where you can notice the thymus, and you can also notice a lymph node. So how do you know this is thymus? I know this is thymus. First of all, both of them are lymphoid organs. Lot of blue dots. Why there are a lot of blue dots? Because the lymphocytes, there is a very thin peripheral cytoplasm. Most of the cell is basically having a large nucleus. So very little of cytoplasm in the periphery. So this is a lymphocyte. How a lymphocyte is identified? Lymphocyte is identified by the fact that very thin peripheral rim of cytoplasm, most of the cell is occupied by a large nucleus, and because nucleus is basophilic blue color, can you see lot of blue dots, million and million of blue dots? So these blue dots, they are nothing but those the lymphocytes, and mostly lymphocytes are not evident, their nuclei are evident. So lymphoid organ is identified by the fact that will have a lot of blue dots, these blue dots. Okay, fine. But where is lymphoid follicle? This is one lymphoid follicle. You see, there is a darker area periphery, then pale area, darker area, pale area, darker area, pale area, darker area, pale area. This is actually a lymph node. In the lymph node there will be a cortex, and in the cortex you will have the B lymphocytes forming these lymphoid nodules. So these are lymphoid follicles or lymphoid nodules in the cortex of the lymph node. Now that is the cortex of lymph node, where you have the lymphoid follicles with the pale germinal center made up of B lymphocyte. If that is the cortex, where is the medulla? Medulla is inside. This is the medulla. So this is the medulla of the lymph node. Yes, there will be medullary sinus, a lot of lymph is filled there, lymphoid sinuses will be there. So that is medulla, that is the cortex. In the cortex you have this B lymphocytes making lymphoid follicle, and the same lymphoid follicles can also be seen in, they can be seen in the spleen, they can be seen in tonsils also, but they are not seen in the thymus. But what is seen in thymus? Thymus, you will find there are multiple cortex and medulla, multiple cortex and medulla. So darker cortex and lighter medulla. So you can see again, this is the medulla and this is the peripheral cortex. Multilobulated organ separated by trabeculae. So you will find that we have got a lot of trabeculations, and because of those trabeculations we will see that the thymus is multilobulated. Multilobulated. You don't have lymphoid follicles there. That was the question. Instead you have multiple lobules, and again appearance is same, outer darker cortex and the lighter medulla. That is thymus. This is thymus. That is a lymph node. So as we look at the question again, our question was asking lymphatic nodules with germinal center are not seen in, and your answer is thymus, because thymus has multiple lobules, doesn't have lymphoid follicles or lymphatic nodules. Okay. As we proceed further, we got one other question. It is asking serous demilune are seen in which type of salivary gland? So there will be two answers, but which one do you think is better? So as you see, if it is asking serous demilunes, first of all, what is a serous demilune? And second thing, it is asking in which salivary gland. So there is a parotid salivary gland which is mostly serous. There is a sublingual salivary gland which is mostly mucoid, but submandibular salivary gland is a mixed salivary gland. It is seromucous, and that is where you will have serous demilunes. So here you can write your answer as submandibular salivary gland greater than sublingual salivary gland. There can be two answers, but serous demilunes are mostly seen in mixed type of salivary gland, which is submandibular salivary gland, though you can see the serous demilunes even in the sublingual salivary gland. Let me show you the diagram, but here the answer should be submandibular salivary gland. So what is about the diagram? You see in the diagram again the same repeat information, as you will notice. If you are talking about the parotid salivary gland, it is mostly serous. So this is parotid salivary gland, and as we are mentioning, it is mostly serous. Serous acini, serous gland are identified by the fact that they are dark staining, darkly staining. Take more of eosin and hematoxylin, more of hematoxylin and eosin, darkly stained. So serous, and this is parotid. What about the sublingual, under the tongue? Sublingual, under the tongue, it is mucinous. Now if you say sublingual is mucinous, how do you identify the mucinous gland? Mucinous gland are basically empty looking cells, mucoid secretions, empty looking. So they don't take much of a stain, maybe hematoxylin or eosin, less of stain. You can see, you can compare the two, this is lightly stained. Then what about the undermandible, submandibular salivary gland? Submandibular salivary gland, if you say, then it is basically mixed type of gland. Mixed means seromucous. What is seromucous? Seromucous means you will have the serous cells and you will have the mucous cells also. And not only that, darkly stained serous cell, lightly stained mucous cell, the lightly stained mucous cell and darkly stained serous cell, you will also have what is called as serous demilune. Let me zoom this a little bit and you can see one of the serous demilune. So what is a serous demilune then? As you will notice, there is one serous gland sitting on the mucus gland. This is the mucus gland. So, on the mucus gland, like a cap on the head of a mucus gland. Serous gland sitting like a cap on the mucus gland. It is a mixed salivary gland, that is where you'll have serous demi-lune. So, this is what you call as serous demi-lune. And serous demi-lune is just it is histological specimen. A section of serous gland has come which was close to the mucinous gland, and they give such appearance like a cap on the head of the mucinous gland. So, you are telling serous demi-lunes is a feature of salivary gland. Yes. And which salivary gland? Though it can also be seen in the sublingual salivary gland, but it is mostly mucus. So, it is serous demi-lune mostly seen in submandibular salivary gland. Now, what is the importance of doing this again? That would be your question. Why you are going so much into detail? First of all, the answer is submandibular better than sublingual. And second thing is this. These are all questions which have come. They would like you to compare salivary gland with the pancreas. Recently, they gave you pancreas slide also. So, what is the question? Question is asking us the striated ducts are present in which gland. So, first of all, what is a striated duct? Which will have striations. And what is striations? Striations means lines. So, where are these lines? What is the answer? Striated ducts are, let me show you one, let me draw a diagram. This is a duct, the lumen of the duct, where you will have saliva, okay. And then these are the cells which are cuboidal cells. So, these are some of the cells which are cuboidal cells. As you look at the salivary gland, for example, parotid salivary gland. Parotid salivary gland, this is the lumen, the duct is lined by cuboidal cells. These cuboidal cells, if you zoom, you will find they will have some basolateral folding. And what is the purpose of having these basolateral foldings? They are the one which create striations. This is a striated duct. But what is the purpose of those basolateral folding? Actually, those basolateral foldings are involved in ion concentration, saliva concentration. So, striated ducts are important because they help in the concentration of saliva. Striated ducts. So, this much of information should be enough for you, and immediately you can write my answer. Striated ducts are present in salivary gland. Now, if you say so, absent in pancreas. Pancreas don't have it. Now, if pancreas is not having it, fine, that can help us to answer some of the questions, but then some more details. As you see, this is a salivon. Now, what is a salivon? Salivon is a unit of salivary gland. So, okay, salivon is a unit of salivary gland. What then? See, there is a serous acinus. And how do you know it is serous acinus? I know it is serous acinus because we are talking about parotid salivary gland. In parotid salivary gland, mostly it is serous acinus. How do you know serous? Because it is darkly stained. They are darkly stained. They take a lot of eosin and hematoxylin as compared with mucinous. They are lightly stained. Okay, so parotid salivary gland, okay, acinus. Then the secretion, the saliva will be given to intercalated duct and then to the striated duct. It is a striated duct which will be having basolateral folding. So, this is a striated duct lumen, and this is the cuboidal cells, and you can see something written here, S. And what is that S? Though we have to zoom, but you can understand that S would be nothing else but the striations. So, you mean to say basolateral striations like this? Yes, that is the S. Let me rub it off, and you can see for yourself. As I rub it off, you will see S. The striations, basolateral striations, to concentrate the saliva ion transport. The cells are involved in that process, and as the saliva passes through the striated duct, the saliva will be concentrated. Saliva was secreted by the serous acini, given to intercalated duct and striated duct, and then to the collecting duct, excretory duct. Like In the parotid gland, you will have Stensen's duct and giving you saliva, upper second molar tooth, opens at opposite upper second molar tooth, parotid salivary gland, duct opening there. So this will be the duct. But in between you have two more, which is intercalated and striated. Now the thing is, pancreas is also having serous acini. Pancreas is also having the intercalated duct, but pancreas is not having the striated duct. You can remember the striated duct were for concentration of saliva, and pancreas is not giving the saliva. So pancreas don't have this striated duct. So what do they have? They will have the intercalated duct and directly the excretory duct. Missing striated duct. They are present in salivary gland. So I am just trying to drive home the information that you should know, because the slide of salivary gland, especially parotid, you can confuse with pancreas. But how can I confuse pancreas slide with the salivary gland? Pancreas will have endocrine component also, islet of Langerhans. Yes, of course, that will help you, but this appears like pancreas actually, parotid gland. So there should be some identifying feature. One of that could be islet of Langerhans. Salivary gland is purely exocrine, whereas pancreas is endocrine plus exocrine. Maybe exocrine appears like this, but endocrine there will be islet of Langerhans. So how the islet of Langerhans appeared like then? So here, as you see, striated ducts are present in salivary gland, absent in pancreas. So where do you have centroacinar cells then? And what is this centroacinar cells? Centroacinar, that means inside the acinus, inside the center of acinus, you will have some cells. Inside the center of acinus, you have cell. What is acinus? That could be serous acinus. So inside the serous acinus, you have some cells. Yes, but cells are at the periphery. What are they doing inside the serous acinus? And where do you see that? Anybody? This is too much of histology, but they are asking what to do. Maybe this was important in first year MBBS, but after that we have forgotten. It is of no use to us, until otherwise in pathology there was some tumors and we were talking about them, but even pathology I have forgotten. It is 5th year of MBBS, I remember nothing. I remember just medicine and surgery, little bit of OBG, pediatrics, and I have forgotten almost 90% of anatomy, some 50% of pathology, and which is very natural. It is natural. If you have not forgotten, then there is something wrong with you. You should forget. But there are some things which you should not forget. And which thing I should not forget? Something which is related with your patients. See, why do we teach you so much? So that if we teach 100 things, at least you remember 10. If I teach only 10 things, then you will remember 1. That is why the syllabus in MBBS is so vast, so much we teach, and then ultimately we don't expect you to remember everything, but you should remember something which is important for you. I really doubt all these things are important at this moment, but then examiner has to examine the student, so he has to prepare some questions. So they have prepared the question, and if they have prepared the question, they have asked the question, I should be able to tell you the answer, and you should be able to remember it so that you can answer it in the exam hall, so that you get a PG seat, and after that you again forget. Until you are finding this important in relation with your patient. Finally, you are doctor, you are supposed to take care of patient. That is the ultimate purpose, and they are important actually. Don't think that they are not important, otherwise why the examiner should be asking you all those details. But what is the answer? Anybody gave the answer? Pancreas. Very good. Yes. Yes, so you remembered your first year MBBS, great. Pancreas. Some people use their common sense, and mostly these questions are common sense questions. Examiners know that you will forget, so they just want you to use your common sense. And though I am smiling, I should not be smiling at the pain of the students. Students feel it very painful because they are, see, there is a boundary. I am here, you are there. So because I have crossed the boundary, I feel everything is easy and simple, and that's what all the faculty keep doing. No, it is not easy, it is not simple, it is very painful process of coming from that side to this side. And I have not forgotten that pain also. I still remember how painful it was for me. So maybe we should not forget our pain. Then only you can appreciate the pain of others. Humility is very important, you know, for a teacher at least, and even for a doctor. Okay, anyway, so this is what I wanted you to understand. Maybe I am taking too much of time here. Barad has come. Good evening, sir. Yes, of course, good evening. Have a nice evening. Though I really doubt interacting with me, you'll find your head will become heavy after some time. So now, okay, let us catch up with the information which we want to deliver here. See, centroacinar cells. This is a histological slide and this is the schematic diagram. You will notice acinar cells, they are cuboidal cells and they are giving us some secretions. These are the secretions, and because it is pancreas, so pancreas will be giving you enzymes, digestive enzymes. So some digestive enzymes are being given by these cuboidal cells, the serous acini, and they will be collected by the duct, which is intercalated duct, and intercalated duct will then pour it into what is called as the collecting duct. So here again you can see this is the intercalated duct, and intercalated duct is taking it towards the collecting duct. The intercalated duct, the cells which are flat nucleus here, flat nucleus, flat nucleus, these cells of intercalated duct, somehow they enter the acinus and they are called as centroacinar cells. The flat cells of the intercalated duct enter the center of the acinus, that is a centroacinar cell, and centroacinar cells are typical finding in pancreas, not seen in parotid. Parotid gland do not have centroacinar cells. Centroacinar cells are seen only in pancreas if you compare the two. Number 2 point was, in pancreas you have intercalated duct but you don't have striated duct. In pancreas you do have intercalated duct but you do not have striated duct. Then what is there? Immediately you have collecting duct. So striated duct is absent in pancreas and centroacinar cells are present in pancreas, and reverse is for parotid. Parotid do not have centroacinar but they do have striated duct. What is the purpose of striated duct? Purpose of striated duct is to concentrate the saliva. What is the purpose of intercalated duct here in pancreas? The purpose of intercalated duct in pancreas is to give you bicarbonate rich fluid. Pancreas is supposed to give you bicarbonate rich fluid. Why should the intercalated duct give me bicarbonate rich fluid? Because pancreatic fluid should come to second part of duodenum, which has received acidic chyme from the stomach. Stomach has HCl acid. That acidic chyme reaches second part of duodenum. You have to neutralize the acid, and that neutralization of acid is done by pancreatic juice. So pancreatic secretions are alkaline, bicarbonate rich, given by intercalated duct. Who is giving the enzymes? The lipase. Who is giving the lipase? The serous acini. And then it is bicarbonate rich fluid which is then poured into second part of duodenum and which was having acidic chyme. Now you can neutralize them. Okay, fine. So eventually what we just want to do is answers. So centroacinar cells are present in pancreas, absent in parotid salivary gland. That was the information I wanted to drive home. What is the answer to this question? तौबा तौबा, सारा कॉन्फिडेंस उड़ गया एक क्वेश्चन में सर. देखो भाई, मेरा पर्पज़ यहाँ पर आकर ये नहीं है कि आपका कॉन्फिडेंस उड़ाना, वो पर्पज़ बिल्कुल भी नहीं है. अब क्या करें कि प्रॉब्लम क्या है? यस, देखो आ गया ना कॉन्फिडेंस वापस? आ गया कि नहीं आ गया? पहले आंसर दो पहले। आ गया ना? देखो किसी भी टीचर का पर्पस ये नहीं होता कि आपका कॉन्फिडेंस नीचे रह जाए, पर देखो सिंपल सा है, मेरा एक सिंपल सा, यू शुड बी कॉन्फिडेंट, you should not be overconfident, you should not be underconfident, you should be having pure confidence. It should not be overconfidence, it should not be underconfidence, it should be pure confidence. And how does that pure confidence comes? By looking at the reality. You should look at the reality. अगर आप देख नहीं पा रहे रियलिटी को, समझ नहीं पा रहे, तो गड़बड़ है। या आप सोच रहे हो कि मैं तो तुर्रम खा हूँ, 30 मार खा हूँ, तो भी गलत है। या आप सोचते मुझे कुछ आता ही नहीं है, तो भी गलत है। तो एक टीचर का काम ये है कि आपको कॉन्फिडेंस देना, आपका कॉन्फिडेंस नीचे नहीं ले जाना, तो फिर गलत हो गया ना। और खासकर एग्जाम अभी कल परसों है और मैं ऐसा काम करूंगा तो अच्छी बात नहीं है। देखो इमीडिएटली आ जाए ना कॉन्फिडेंस। ऐसा नहीं है सारे सवाल मुश्किल नहीं होंगे, 10% ही मुश्किल होंगे। प्रॉब्लम ये है कि 10% से ही तो रैंक आता है। यही तो, आसान सवाल तो सारे ही दे देंगे। एनीवे, सो ITO cells, stellate, hepatic stellate cell of ITO, which can help you in storage of vitamin A, and which can also help in giving you reticular fibers. Liver is again lymphoid organ, it will have reticular fibers. Sometime it may happen that hepatic stellate cell of ITO are forming more of fibers, that is fibrosis, that is cirrhosis. So when you talk about cirrhosis of liver, there is lot of fibrosis, and that is lot of fibrous reticular fibers. Who was making that? One of such cell, which could be due to injury, maybe somebody taking lot of alcohol. So taking lot of alcohol, this ITO cell get irritated and will say, what are you doing? Why are you damaging your liver? Let me give you some fibers now. So ITO cells, which are and these people will have vitamin A deficiency also. They will have lot of deficiencies if you keep on taking lot of alcohol. Calorie deficiency, vitamin 12, B6 deficiency, Wernicke's, Korsakoff psychosis, all that. You should take alcohol, but should not be living on alcohol. Otherwise, fibrosis, cirrhosis, portal hypertension. There is a question on portal hypertension also. Everything is related, of course. Anyway, you already have answered. Located in the space of Dece, and the space of Dece is perisinusoidal. So perisinusoidal space of Dece. Let me show you the diagram for that purpose. You see here. So what you find is, see, first of all, because this is liver, we are talking about liver. So liver will have the cells here. These are the cells of liver, and which are hepatocytes. This is the nucleus of hepatocyte. But along with that hepatocyte, between the hepatocytes, say one other hepatocyte is here. Now between the hepatocytes you will have the sinusoids, hepatic sinusoids, which are fenestrated. So fenestrated hepatic sinusoids. So let us say these are the hepatic sinusoids which are fenestrated. Fenestrated means no tight junction of endothelium. Sinusoids are lined by endothelium, and these endothelial cells, they are not making tight junction. So there are some spaces, and through those spaces you will find the Kupffer cell. Kupffer cells, they are phagocytic cells. Their pseudopodia, they keep giving that out. So where will you find Kupffer cell? Of course in the blood vessel. So in the blood vessel I have this Kupffer cell. What is it doing? It is sending pseudopodia here and here. So inside the hepatic sinusoid you will have the Kupffer cell, which is a kind of a macrophage, lot of pseudopodia, and those pseudopodia are sending into this perisinusoidal space of Dece. What else do you find in the perisinusoidal space of Dece? The microvilli of hepatocytes. So microvilli of hepatocytes are where? In the perisinusoidal sinusoidal space of DC, which I can label here if you wish. Say we can label it with this color. So this is the space. So this is the space. Let us increase this space because it is around the sinusoid. So perisinusoidal space of DC. Actually, they'll ask you what all is there in the space of DC. It is the microvilli of hepatocytes, and it is a pseudopodia of the Kupffer cell, which actually is inside the sinusoid but sending pseudopodia outside. And what else? This cell. Who is this? This is the cell which we were asked about, and you can name it now. Let us take some other color. This is the Ito cell, hepatic stellate cell of Ito. It will have a lot of lipids and lipid depending storage of vitamin A also. And it is the one which, if insulted, if any insult is there, a lot of alcohol in the blood, it feels irritated, a lot of fibers, reticular fibers, and fibrosis and cirrhosis. So one of the culprit cell in liver cirrhosis is Ito cell, lying in perisinusoidal space of DC. Okay, fine. Let us move on to this question. Arrange the cells in seminiferous tubule in basal to luminal side. Seminiferous tubule means testis. Now, if it is the testis, basal to luminal means what? Means in testis you will have lot of seminiferous tubules, and then in the lumen you will have the sperms. Okay. If the lumen has the sperm, then towards the base which cell will be there? So they are asking from base towards the lumen. Yes. What are these? What are the name of these cells? And arrange them in a sequence, because INI-CET exam they can give you A, B, C, D and arrange in a sequence. That kind of questions come. So what should I answer? For that purpose, let us look at the diagrams, because you know in histology recently they have started giving diagrams and you should be able to handle them appropriately. So you are talking about spermatogenesis here. Of course, spermatogenesis, because you are talking about seminiferous tubule, so spermatogenesis. But the sperms, as you can see in the lumen, say this is the sperms in the lumen. But what are these cells which are from basal to luminal side? That was the question. See, very much around the seminiferous tubule, very much around the seminiferous tubule, you will have what is called myoid cells. Myoid cells, and these myoid cells, as you can notice here, the flat cell with flat nucleus, they will be towards the basal side. Now, if the myoid cells are towards the basal side, what about the gametogenic cells? Gametogenic cells you can start with what is seen here, spermatogonia, then primary spermatocyte, then you may sometimes see secondary spermatocyte, though it is short lived, and then spermatid, and then spermatozoa. It is the same way as you can see here. See, what is the first thing you see? Spermatogonia, basal, and after that primary spermatocyte undergoing meiosis 1 to give you secondary spermatocyte, which will undergo meiosis 2, which will give you spermatid, which will undergo spermiogenesis and then form the spermatozoa, which will be in the lumen. So, which is the parent cell? Parent cell is primordial germ cell, but primordial germ cell would have formed spermatogonium. Primordial germ cell will form spermatogonium when? Primordial germ cell will form spermatogonium only after puberty. The meiosis or gametogenesis, the meiosis begins in males. Meiosis begins in males only after puberty. So, meiosis in males began only after puberty, because primordial germ cell is dormant till puberty in males, not females. Females meiosis begins even before birth, in utero in fact. So, meiosis would have begun in female baby while the baby was in utero. But in male, meiosis begins only after puberty. So, till puberty you do not have the primordial germ cell giving spermatogonia. Okay, after spermatogonia you will have primary, secondary spermatocyte, then spermatid and spermatozoa, basal to luminal side. Same thing shown here. This is one of the seminiferous tubule, this is another seminiferous tubule, and Then you have this myoid cells which are squeezing the seminiferous tubule so that the spermatozoa which are formed can be pushed further towards the urethra, because eventually sperms are to be ejaculated by urethra. So the purpose of myoid cell, they are contractile cells, they squeeze the seminiferous tubule to push the sperms further in the reproductive tube towards the urethra. Though urethra is very far, after seminiferous tubule you will have rete testis, you will have efferent tubules, you will have ductus deferens, you will have epididymis and all that. Eventually urethra will come. I am not going into detail of how to identify these cells, but that is the arrangement. So already I think you have got your answer and we can proceed further. What is the type of joint at the middle, tibiofibular joint? Type of joint, middle fibula, tibiofibula. The middle of tibia and fibula, what do you think? It is the same as you see in the radio ulna. So tell me, fibrous, yes. Can you tell me the anatomical name? Fibrous is good. Name? Syndesmosis, yes. Desmos fiber. So it is syndesmosis and desmos is fiber. It is a fibrous joint, yes. Now the thing is, if you say this is radius and this is ulna, can you tell me what type of joint is here and here? Superior radioulnar joint and inferior radioulnar joint. If this is radius, that is ulna, superior inferior radioulnar joint is which type of joint? Superior radioulnar, inferior radioulnar is which type of joint? It is synovial. Which synovial? Superior, inferior radioulnar joint where you have supination, pronation, pivot. It is a pivot synovial joint. Now when you say superior radioulnar, inferior radioulnar is pivot synovial, right, as PPP has answered P, pivot. What about the tibia and fibula? If you say this is now the tibia and this is the fibula. Now superior tibiofibular, inferior tibiofibular, what is the answer? Superior tibiofibular, inferior tibiofibular. If you say superior tibiofibular, it is synovial and it is plain synovial. That will be near the knee joint. So near the knee joint, superior tibiofibular joint, near the knee joint will be plain synovial. What about the inferior tibiofibular? What about the inferior tibiofibular? That is actually a question. Inferior tibiofibular joint is again a syndesmosis. Syndesmosis. So can you give 3 examples of syndesmosis just now we have discussed? The 3 examples of syndesmosis which we have just discussed are middle radioulnar joint and the middle tibiofibular joint and even the inferior tibiofibular joint. So middle radioulnar joint, syndesmosis, middle tibiofibular joint, syndesmosis, inferior tibiofibular joint, syndesmosis. Then what is superior inferior radioulnar joint? Pivot synovial. And what is near the knee joint? Superior tibiofibular joint. Superior tibiofibular joint is a plain synovial joint. Okay, right. So this was histology, arthrology, and we can move on to the neuroanatomy now. As you move on to neuroanatomy, you will find a lot of questions. What do you think is the answer to this question? Fornix. Tell me. Fornix contains which kind of white matter fibers? Basically axons. So fornix is made up of axons, and which kind of axons? White matter fibers are 3 types and it contains all the 3 types. If you say white matter fibers are 3 types, it contains all the 3 types, which should be my first answer? what should be the sequence? So, it is quite a controversial question, but I will help you to remember CAP. Remember CAP. What is CAP? That it has commissure fibers. It has commissure fiber, and A association fibers, and P projection fibers. What is this commissure, association and projection fiber then? Mammalian and hippocampus connect, commissure fiber, yes, association, yes, yes, yes. Now, I find that different faculties will give a different order of which should be the first answer, second answer, third answer. Actually, we do not have a criteria to tell that which should be first, second, third answer, but in my experience, I believe that first answer should be commissure. Why first answer should be commissure? See, fornix is the major output tract of hippocampus. And what is hippocampus? Hippocampus is the seat of short term memory, short term memory. So, telling hippocampus is for short term memory, like explain short term memory. Short term memory, like what breakfast did you take today, is short term memory. Okay, today I took nothing, okay, but still that is short term memory. So, that will be stored by hippocampus. Hippocampus will give it further via fornix. It is a major output tract for hippocampus to convert it into long term memory, consolidation of memory, consolidation of memory, and that circuit is called Pape's circuit. Lot of questions coming on Pape's circuit. So, you are telling that the hippocampus will help me to remember that I took nothing today in breakfast for long term. Yeah, if it is important, of course, because brain has a filter system also. Some unnecessary useless things will be filtered out. Sometimes useful things are also filtered out. So, hippocampus converts the short term memory into long term memory using fornix, because it is a major output tract for the hippocampus. So, you are talking about consolidation of memory. Yes, consolidation of memory, and in that consolidation of memory, the circuit used is Pape's circuit. Now, what is this Pape's circuit? Pape's circuit is a question which is coming to you in the last 5 years, in the last 20 years actually, multiple times, and still coming. And why is still coming? Because neuroanatomy is something which you cannot master, even if you have been neurosurgeon or neurophysician for 50 years. So, there is always something which they will be surprised to know this is also there. So, that kind of thing is there, but anyway, my purpose here is not to make you lose confidence, but to rebuild the confidence, or whatever confidence you have should be strengthened. That is the purpose. Okay, so you are telling that fornix is some axons. Yeah, of course, axons, because it is the major output tract. When you say output, output means the efferent, outgoing, efferent, efferent, E for exit, E for exit, E for efferent, but means outgoing. Okay, so the major output efferent fiber from the hippocampus is fornix. Where is it going? Where is it going? So, that all we will find, but one hippocampus is connecting with other hippocampus, means right hippocampus connect with other left hippocampus via commissure fibers, and that commissure fibers also belong to fornix. So, first answer is commissure. Second is association. What is association? Association means you do not cross the midline, you keep connecting brain on the same side. So, keep connecting brain on the same side, like what is it connecting? Like it will connect hippocampus with mammillary body of hypothalamus. So, fornix will carry the information to mammillary body of hypothalamus, that is association fiber. Association fiber do not cross the midline, it keeps connecting part of brain on the same side. Okay, so you are telling it is having association fiber now, yes, and what is it connecting? Connecting the right sided hippocampus with the right sided mammillary body, which is a part of hypothalamus, using the fornix. Okay, so fornix reaches mammillary body of hypothalamus, yes. What about the projection fiber? Projection fiber is connecting higher brain center with the lower brain center. Let me show you a diagram, and as you see that diagram, you will find that the fibers we are talking about could be, number 1, the crossing fibers. Like one good example is corpus callosum. So corpus callosum is commissural fiber connecting right brain with the left brain. Now this is corpus callosum, which is commissural fiber. Where is association fiber? Association fibers, they do not cross the midline. Let me use some other color. They do not cross the midline, they keep connecting brain on the same side. So there will be association fibers. Okay, so these are association fibers. Can you give one example? Association fiber, one example is on the left side you can say the Wernicke's area connected with Broca's area by arcuate fasciculus, arc-shaped fasciculus. So Wernicke's area with the Broca's area connecting is arcuate fasciculus on the same side? Yes, on the left side. Do not cross the midline. So arcuate fasciculus is association fibers. Yes, arcuate fasciculus, we will see in a diagram also, is association fibers. Okay, then what about the projection fibers? If you say the projection fibers, then you can look for yourself. Say, let us use some other color, black is good. And this is the projection fiber. This is basically internal capsule. So now we are looking at internal capsule, yes, and internal capsule is projection fiber. Projection fiber means projecting from upper brain center to lower brain center or vice versa. So projecting from upper brain center to lower brain center or vice versa is projection fiber. One of the example is internal capsule. How do you know this is internal capsule? I know this internal capsule because of its location. It is actually sandwiched between thalamus on the medial side, caudate nucleus on the medial side, whereas lentiform lens-shaped nucleus on the lateral side. So lentiform nucleus, some gray matter, yes, and thalamus, some gray matter, yes, and caudate, some gray matter, yes, gray matter sandwiching white matter, and that white matter in such relation where lentiform is always lateral, L for L, lentiform is lateral. If lentiform is lateral, then medial is thalamus and the caudate. This is internal capsule, it is a projection fiber. So you should be able to identify these structures. But where is fornix in this diagram? In this diagram, the fornix, yes, where is the fornix? In this diagram, if you want to see the fornix, then let us show it. We can zoom it a little bit, and you see this is fornix. Where is fornix? This is right-sided, sorry, this is right-sided fornix, and that some other color. This is left-sided fornix. I can rub it off so that you can see clearly yourself. So this is fornix. Remember, fornix is connected to corpus callosum by what is called as the septum pellucidum. Septum pellucidum, which is basically separating the lateral ventricle of one side from lateral ventricle of other side. Lateral ventricle, this dark color filled with CSF. So that dark colored structure filled with CSF on right side, dark colored structure filled with CSF on left side, separated by septum pellucidum. And what is septum pellucidum doing here? It is lying between corpus callosum superior and fornix inferior. So this is fornix, that is septum pellucidum, that is the corpus callosum. This is the relation. And why I am so much specifying it there? Because examiner will do this: A, B, C, D, E, F, G, H. Can you see the hippocampus here? Can you see the hippocampus here? Hippocampus is here. Hippocampus will send the fibers via fornix to the mammillary body. Now if hippocampus is sending fibers through fornix to the mammillary body, where is mammillary body? You cannot see mammillary body here that clearly, but we have other diagrams for that. Okay, what is happening? What is happening is you are preparing for your INI-CET exam. That is what is happening. Don't bother too much by my teaching. I usually bombard the student with a lot of information with the purpose that at least you remember 10% of it, and you will be benefited. So when you give too much of information, something is remembered. If I give very few statements, then very few would be remembered. So, and I repeatedly keep telling things so that whatever is important should be remembered. Anyhow, you know, commissure should be your first answer, because connecting right hippocampus with left or vice versa is the job of fornix again. So commissural association and projection, that was our question. We should not forget to find the answer to our question, otherwise the purpose of this class is not fulfilled. So there is no problem here at all, because question is asking measure output from hippocampus. Output means exit, exit means efferent. So what is that? Fornix. And where is it going? Mammillary body. And what is mammillary body? It's a part of hypothalamus. And what is the purpose? Purpose is consolidation of memory. And what will happen if I have a problem with the fornix? If you have a problem with fornix, then you will have amnesia syndrome. Amnesia syndrome, forgetfulness. You cannot convert your short term memory into long term memory if there is a lesion of fornix. What lesion of fornix? What are you talking about? They already have asked you the blood supply, arterial supply of fornix. So what will happen? You mean to say some arteries will be compromised, and then the fornix will die, and then there will be amnesia syndrome. Yes, that is, you see, you are a doctor, you are a physician, you are supposed to connect the dots. The patient comes into your clinic, right at the door. Our professors used to teach us like that. You know, in government hospitals, government colleges, it is like that. One professor, 40 students are in one unit, and they are all standing on the head of the professor. Professor, hey, get away, go away, go away. Look at the patient coming from the door, and everybody is looking at the door. What? Then some patient will enter, and then look how he is walking, look how he is coughing, look how in distress he is. So they will teach just by looking at the patient entering the door, he will make his diagnosis, and surprisingly very good at that. So the thing is, they connect the dots. You should be good at connecting the dots. Sir, which question have they asked? Arterial supply fornix? Yes. Can you tell me the answer? What is the arterial supply of the fornix? See, fornix is basically a midline structure. So an artery which supply the midline structures of brain. Fornix is, it is a U-shaped structure, C-shaped structure near the midline. So any artery which supply the medial aspect of the brain. So who is that? We will find out. But if you want the answer, I will tell you here itself. It will be the branch of internal carotid artery, anterior cerebral artery, and connecting the two anterior cerebral artery, anterior communicating artery. And these questions have already appeared. I teach you nothing which the examiner has not asked yet. And what I do is, whatever they have asked, I will ask you, tell you, and then add a little bit more to that. So already this question has come, the arterial supply to fornix, and it is anterior cerebral artery, because anterior cerebral artery is the major artery supplying the medial side of the brain, and connecting the two anterior cerebral artery is anterior communicating artery. So even anterior communicating artery supply the fornix. So the point is, if there is a block in anterior cerebral artery or anterior communicating artery, you will have ischemia of fornix, and you will have amnesia syndrome. Connecting the dots. So this is the diagram which you should be aware of, and it is a repeat information. We are talking about Papez circuit here. Papez circuit. Papez circuit belongs to limbic system, and limbic system is very old system in evolution. Even animals have quite well developed limbic system. It is related with the survival, and survival is related with two things, food and sex. Food to survive, sex to perpetuate the species. So, Pape's circuit is limbic system. Limbic system is very old in evolution. Even animals will have very strong limbic system, like humans are animals, sophisticated animals. They also search for food and sex, but sophistication is there. Some are not sophisticated, some are sophisticated. So, it is about survival, and you survive by having food, and then you perpetuate your species by having sex. So, it is related with that. But since humans have evolved, what came into play is emotions and behavior and memory. Your memory should serve you. If you had a bad interaction with other opposite sex once, you should not have, it is not necessary that you continue with that bad behavior with other opposite sex. So, you learn. How do I learn? Emotions, behavior, memory and smell is also related. So, this is all about Pape's circuit, limbic system, memory, converting short term memory into long term memory. Your behavior will modify so that you can have better food in life. As you proceed in life, you would like to have better food and you would like to have better sex. Sir, what do you mean by better sex? Better sex means in the early life you may have some girlfriends, but eventually you will settle with the lady who is your wife or husband. And it was funny, though it is not funny, but I was watching one TV serial, Diplomat, on Netflix, and this one of the lady, she becomes a diplomat of US to UK. She is in England, and her husband becomes wife. So, that is kind of the way they talk. So, means if a lady is a diplomat, then that lady's husband is her wife. So, it is funny kind of, but English language or maybe the way they use the terminology. So, that man is the wife of this lady basically. So, my point is, in due course of time, you should evolve your emotion, behavior and memory so as you marry somebody decent, and of course, if you marry somebody decent, you will have a decent sex. That is also shown in the serial. And so, that is about Pape's circuit or limbic system. But what about the neuroanatomy, sir? Neuroanatomy, of course. So, you can start with the hippocampus. And as you start with the hippocampus, hippocampus is in the inferior or temporal lobe of the cerebrum. So, hippocampus is in the inferior temporal lobe of the cerebrum, and it was giving one major output. That major output was as we already have mentioned, the fornix, C-shaped fornix, that is the C-shaped fornix, and this fornix is the efferent to where? It is towards the, let us use some other color, mammillary body, which is hypothalamus. Then there is a mammillothalamic tract, and this mammillothalamic tract, as you will notice, is going to anterior nucleus of thalamus. So, this is mammillothalamic tract, and mammillothalamic tract means, as the name is suggesting, anterior nucleus of thalamus. These are all MCQs. If you have been through the last 5 years MCQs in INI-CET exam, you will know everything what I am talking about. It is just a revision. So, mammillothalamic tract is coming from mammillary body towards the thalamus, the anterior nucleus of thalamus, and from the anterior nucleus of thalamus, another loop starts. See, this is one loop. There is another loop, and that loop is from here. Now, the fibers will be going to, say, let us use this color, cingulate gyrus, which is above the corpus callosum. So, above the corpus callosum, you will have cingulate gyrus. From anterior nucleus of the thalamus, from anterior nucleus of thalamus, the fibers will reach the cingulate gyrus, and from cingulate gyrus, they will come back to hippocampus. They will come back to hippocampus. So, you can see the two loops, 1 and 2, 1 and 2, 1 and 2, and they keep doing that for consolidation of memory, so that you have better emotions, better behavior, better interaction with smell. What is smell doing here? Smell has a role. This pathway passes through entorhinal cortex where you have olfactory pathway. So, olfactory pathway smell, entorhinal cortex also comes into this pathway. So, entorhinal nose, smell. So, entorhinal cortex is also in a Papez circuit, yes. Recently a question came, amygdala is also a part of Papez circuit, and that is the latest question. So, amygdala is also part of Papez circuit, means limbic system, yes, limbic system. So, it is never ending story. The more you read, the more you realize that you know nothing. The more you read, the more you realize that you know nothing, and it is good, it will keep the humility intact in you. Otherwise, you will be like, you should not be overconfident, but you should not be underconfident also. You should be confident, and the confidence comes with hard work and smart work. Hard work, smart work. Just smartness will not help you, and just hard work will not help you. So, hard work and smart work. What is this hard work and smart work? Keep practicing previous year questions, you will become smart, and keep practicing means you become hardworking. So, as you practice previous year questions, you become smart, and as you keep practicing, you are working hard. So, hard work and smart work, that will give you the whatever you want in life actually, not only clearing your PG entrance exam. And I do not know, I am lagging behind in time. So, what was the question? We should not forget our questions. Major output from hippocampus is of course fornix towards the mammillary body. Yes, that we have answered. What about this question? Mammillothalamic tract. Now, there should not be any problem at all, isn't it? So, mammillothalamic tract, synapses in which nucleus of thalamus? Anterior nucleus of thalamus, and from there it goes to cingulate gyrus, and from cingulate gyrus where it goes? From cingulate gyrus. Remember, cingulate gyrus is for satisfaction. It works for satisfaction. Satisfaction. What kind of satisfaction are you talking about? Cingulate gyrus works for satisfaction. Satisfaction could be after food, after having sex, that kind of satisfaction. Okay. So, a schematic diagram again, same diagram, but schematic, and as you revise, see, my point is you should not miss the important points, and important points are: start with hippocampus in the Papez circuit, you use the fornix, go to mammillary body, from the mammillary body you are going to anterior nucleus of thalamus, and from anterior nucleus of thalamus you are coming back to hippocampus via the cingulate gyrus, and this goes on and on and on, so that you have better memory, better emotions, behavior and all that. This is limbic system, this is Papez circuit, should not forget, because this question in the last 5 years in INI-CET exam only have come 5 times, and every time they add something. Like recently what they added was, I never used to teach amygdala as a part of limbic system, but they have asked this. They must have attended my classes, they must have found what he is not teaching, and whatever he is not teaching, let us ask that. What is this? Intraperitoneal fallopian tube, what is this? How is ovary located, sir? It is intraperitoneal, extraperitoneal. Why fallopian tube open into peritoneal cavity? If so, ascites in female will come out through vagina, explain, sir. This is a different topic, of course, but if you ask me, see, reproductive system is different, though it is covered by peritoneum, but it is not as such intraperitoneal. So, if you talk about the uterus, uterine tube or ovaries, they are definitely covered by peritoneum, but you cannot say intraperitoneal. Now, the thing is, Of course, fallopian tube opens into the peritoneal cavity, but just for the purpose that when the ovary will give you secondary oocyte, it has to catch the secondary oocyte and take it inside uterine tube for fertilization. I will repeat again. Though uterus and uterine tube and ovaries, the female genital system is covered by peritoneum, but they are not intraperitoneal. Point 2, fallopian tubes do open in the peritoneal cavity, yes, but purpose is to catch the secondary oocyte which was ovulated by ovary and bring it towards the ampulla of fallopian tube so that you can have fertilization. Now, your question is, when there is ascites, which is fluid in the peritoneal cavity, can the fluid in the peritoneal cavity, the ascitic fluid, enter the fallopian tube and the uterine tube and the uterus and the cervix and the vagina and come out of vagina? Of course, but it's too much of thinking, means maybe it is possible hypothetically, but nobody has this is what inquisitive mind is, but it is a possibility. Of course, ascitic fluid can enter the fallopian tube into uterus, into cervix, into vagina, but just imagine what are the chances. That won't happen, I think, in real life, but there is a possible, hypothetically it is possible. Why should the cervix open just like that? It will open when there will be flow of menstrual flow will be there, and with menstrual flow maybe some ascitic fluid will also come out, maybe. But it's a good question. People should be inquisitive, yes. See, ovary, if you say ovary, ovary is a organ which is covered by peritoneum, of course, but it is not intraperitoneal. Intraperitoneal, if you want to understand, gut tube is intraperitoneal, though not entire gut tube. Stomach is intraperitoneal, but you cannot say that ovary is intraperitoneal. There are terms, actually various terms, intraperitoneal, but so I do not want to go into those details because this session is different. We should not lose track, but I hope I could answer some of the queries which you were looking for. Okay, tell me about this conduction aphasia due to lesion in. So, conduction aphasia is a kind of a speech problem where comprehension is intact, fluency of speech is intact, but there is a problem in repetition of language. So, conduction aphasia where comprehension means understanding of language comprehension is good, fluency of speech is good, but there is a problem with poor naming, poor repetition of language. So, that is conduction aphasia, and it is a problem of, if you remember, we have discussed arcuate fasciculus, which is connecting Wernicke's with Broca's left side, that association fibers. So, it is a problem of that association fiber. Let me show that in a diagram here. These questions again they have come, so I want you to remember some details which you must be knowing, but it is kind of a repetition. So, where do you see the Wernicke's area? Wernicke's area is basically on the superior temporal gyrus, on the superior temporal gyrus more posteriorly, area number 22, Broadman number 22. So, superior temporal gyrus more posteriorly. Superior temporal gyrus more posteriorly is Wernicke's area, and the purpose of Wernicke's area is understanding the language, comprehension of language, and then it will communicate with the Broca's area. Broca's area is inferior frontal gyrus. This is the frontal lobe. In the frontal lobe, this is inferior frontal gyrus. So, inferior frontal gyrus on the frontal lobe is Broca's motor speech area. That is Wernicke's sensory speech area. And Broca's motor speech area. How the Wernicke's area communicate with the Broca's area is by a bundle of axon which is arc shape bundle of axon, hence the name arcuate fasciculus. If there is a problem with the arcuate fasciculus, then there will be conduction aphasia. These patients, they will have intact comprehension, understanding of language is good. They have intact fluency of language is good, but there is a problem with poor naming, poor repetition of language, that is called conduction aphasia. So that was the question. There are other questions also. They will ask you, there is a lesion in the posterior part of temporal gyrus, superior temporal gyrus, what kind of aphasia? You say Wernicke's sensory aphasia. And how do you identify that? There will be non-stop nonsense speech. And why would the patient have this nonsense and non-stop speech? Because there is a problem with his Wernicke's area, though I can explain it further, but just remember non-stop nonsense speech, somebody is just babbling which you cannot understand what he is talking about. So that will be Wernicke's aphasia. And how do you identify the Broca's aphasia, motor speech aphasia? Broca's aphasia is identified by the fact that these people are mum, they do not speak much, they never make sentences, they use only few words. So few words they use and they keep mum, they do not talk much. So fluency of language is compromised. Fluency of language is compromised, they do not speak much, they do not make sentences, they use just few words. Problem is inferior frontal gyrus. Inferior frontal gyrus, Broca's motor speech area number 44, 45, double the number of Wernicke's. Wernicke's is 22, Broca's is 44. It is 44, 45. Decussation of superior cerebellar peduncle at the level of. Where do you find the decussation of superior cerebellar peduncle? Then how it releases ova in the peritoneal cavity? Ovaries, inside ovaries you will have secondary oocyte inside Graafian follicle. There is a break in the surface of ovary and there is extrusion of secondary oocyte into peritoneal cavity. Ovary, the surface ruptures and releases the ova into peritoneal cavity. There will be a break in the surface of ovary, there is a break in the Graafian follicle, fuses with the surface, ruptures and later that seals off. That is how the ova will be pushed into the peritoneal cavity. So tell me, decussation means crossing of superior cerebellar peduncle is at the level of. It is at the level of midbrain first of all, at the level of inferior colliculus, near the pons. So it is in the midbrain at the level of inferior colliculus, means lower midbrain, at the level of inferior colliculus and near the pons. So what does it mean? It will become more evident when you look at the diagram here. See, sometimes the examiner will give you a section. You must have learnt in your first year MBBS also, they give you these diagrams. You can see this is aqueduct of Sylvius and this is periaqueductal grey matter. This is colliculus, the inferior colliculus. So transverse section of midbrain. Transverse section of midbrain, this is dorsal, this is ventral. On the ventral side of midbrain, you will have crus cerebri on either side. This is crus cerebri on either side. You can also see substantia nigra in the midbrain on either side. And this is the decussation of superior cerebellar peduncle. So the point is, Superior cerebellar peduncle basically carry axons and they cross the midline. In the lower midbrain, why you say lower midbrain? Because in the lower midbrain you have inferior colliculus. In the upper midbrain you have superior colliculus. Inferior colliculus, inferior midbrain or lower midbrain. Colliculi are dorsal and crus cerebri are ventral. This is substantia nigra, that is where the decussation is happening. Is that where you have red nucleus? You say no. We don't have red nucleus here because red nucleus will be at the level of superior colliculus. Red nucleus location is this, but it will be found in the upper midbrain at the level of superior colliculus, not inferior colliculus. So, you will not see red nucleus here, though you will see substantia nigra at both levels. Substantia nigra is here at the level of inferior colliculus and substantia nigra is there at the level of superior colliculus also, but red nucleus is only at the level of superior colliculus. All these are MCQs. So, what is this decussation and what is all happening here? Say you are walking in a straight line, you move your right lower limb and there is a change of position of right lower limb that is carried by. You are walking in a straight line, you move your right lower limb. As you move the right lower limb, the position of right lower limb, proprioception, position sense. The position sense or proprioception of right lower limb is carried by right spinocerebellar tract to the thalamus, to the cerebellum, same side. So, which tract is this? This is right-sided spinocerebellar tract. This is right-sided spinocerebellar tract. So, what is this right-sided spinocerebellar tract carrying? It is carrying the proprioception from the lower limb. And where is it taking it? To the same-sided cerebellum. There will be some synapses and eventually the information will go to dentate nucleus of thalamus, and from the dentate nucleus of cerebellum, from the dentate nucleus cerebellum there will be a dentatothalamic tract. That dentatothalamic tract will of course reach the thalamus, but on the contralateral side. So, dentatothalamic tract, which you see here, dentatothalamic tract will cross the midline of the body and synapse in the other sided thalamus, means contralateral thalamus. Where is the decussation happening? That is the point. So, decussation is happening here. Where? At the level of midbrain, lower midbrain, near the pons. This is pons, this is midbrain, and this is medulla oblongata, that is brainstem. Brainstem has three components: midbrain, pons and medulla oblongata. So, at the junction of midbrain and pons, you can say, or near the pons in the lower midbrain, at the level of inferior colliculus, you have this crossing of fiber. What is the purpose of knowing all this? Purpose is simple. If I have ischemia at the level of red nucleus in the midbrain, if I have ischemia at the level of red nucleus in the midbrain on left side, means lesion at the level of superior colliculus. If I have a ischemia of left side midbrain, upper midbrain at the level of red nucleus, superior colliculus, where will be cerebellar ataxia? Which limb will lose walking in a straight line? Or cerebellar ataxia means cerebellum will not function properly, contralateral. The problem will be contralateral. So, if I have a lesion in the left-sided midbrain at the level of superior colliculus or red nucleus, fibers have already crossed. And if the fibers have already crossed, problem will be contralateral. And what if I have a problem somewhere here before that? Then problem will be ipsilateral. So, lesion before decussation and lesion after decussation. If there is a lesion after decussation, problems are contralateral, and if there is a lesion before decussation, problems are ipsilateral. That is the only purpose of this question. Say for example, lateral pontine syndrome. Lateral pontine syndrome, ipsilateral cerebellar ataxia. lateral pontine syndrome, ipsilateral cerebellar ataxia, and if it is midbrain syndrome, then contralateral cerebellar ataxia. That this question, cerebellar decussation, has appeared 2-3 times. You should understand why they are asking this question. And anyway, you have answered. Decussation of superior cerebellar peduncle occurs at the level of lower midbrain, at the level of lower colliculus, inferior colliculus, the level where you do not have red nucleus. All of these are MCQs. What I am wearing in my hand is called as palm rejection tool. When I write on touch screen, I just want to touch my pencil, but if my palm is touching, then the screen will wobble. So, it is kind of a resistance. When I touch on the screen, it does not detect that. If I touch, if I remove it, then you will find the screen is all the time moving this way. It is not static. So, palm rejection. Anyway, this all comes with time. One of my friend, Dr. Tamim, actually Dr. Tamim is, you might be knowing Dr. Tamim. Dr. Tamim is my batchmate. He teaches medicine presently at Dr. Bhatia Medical Institute. So, he told me about this palm rejection glove. Okay. Efferent fibers from cerebellum arise from. I need to give some hint here. Efferent outgoing, exit. Exit means outgoing. Fibers from cerebellum arise from. See, just now we have seen some pathway. I will repeat the pathway. Say this is the brain stem, 3 parts, midbrain, pons, medulla oblongata. Below this will be spinal cord. So, this is spinal cord, this is brain stem having 3 parts, medulla oblongata, pons, midbrain. This is midline of the body, looking from the front view. So, this is right side, this is left side, right, left, looking from front view. Just now I have told you that right lower limb pathway, and let us show the cerebellum also. This is the cerebellar hemisphere right, cerebellar hemisphere left, connected to the brainstem by peduncles. Cerebellum right, cerebellar hemisphere, left cerebellar hemisphere, connected to the brainstem by peduncles. This is superior cerebellar peduncle midbrain, middle cerebellar peduncle pons, inferior cerebellar peduncle medulla oblongata. Superior cerebellar peduncle midbrain, middle cerebellar peduncle pons, inferior cerebellar peduncle medulla oblongata. So, the pathway which we are talking about, say right lower limb proprioception position sense carried by right spinocerebellar tract. So, this is right spinocerebellar tract carrying the right lower limb position sense proprioception. Using inferior cerebellar peduncle reaches here, using inferior cerebellar peduncle reaches here. So, inferior cerebellar peduncle will have a pathway which is called spinocerebellar tract running ipsilaterally, same side, and then it will be synapsing in granule cells, and these granule cells will then be found in cerebellar cortex. In cerebellar cortex there are 3 layers and 5 cells. In cerebellar cortex there are 3 layers and 5 cells. The inner layer is GG cell, GG, one is Golgi, one is granule, and in the middle you have a P, Purkinje cell, and in the outer layer you have SV cell, stellate and basket cell. I will repeat. What are the 5 cells in the 3 layers of cerebellar cortex? In the 3 layers of cerebellar cortex there are 5 cells. Inner layer is, deeper layer is GG cell, one is granule, one is Golgi cell, middle is Purkinje cell, outer layer is SV cell, stellate and basket cell. Now this information of right limb position sense which came by spinocerebellar tract came to granule cell. Granule cell will tell all the other cells about this information and they process the information. So as they process the information, the outgoing pathway out of these 5 cells is only with one cell. So only efferent outgoing from the cerebellar cortex is Purkinje cell, and Purkinje cell will send it where? It will send it to what is called as dentate nucleus of the cerebellum, deep cerebellar nucleus. So a question can come, there are 5 cells in the cerebellar cortex, but only one cell has efferent or outgoing fibers. The only efferent is with the Purkinje cell. It uses GABA, gamma aminobutyric acid, which is a neuroinhibitory transmitter. So out of these 5 cells, the only output is by Purkinje cell, which uses GABA on dentate nucleus, and from the dentate nucleus you already have discussed there was dentatothalamic tract crossing the midline at the level of inferior colliculus midbrain. So it will be like this, going to thalamus on this side, contralateral thalamus, dentatothalamic tract. So dentatothalamic tract, superior cerebellar peduncle. The superior cerebellar peduncle decussates at lower midbrain and reaches contralateral thalamus. This is what we already have discussed. Now, question is asking, efferent fibers from cerebellum. See, there is a difference. One question is efferent fiber from cerebellum, other question is efferent fiber from cerebellar cortex, and the answer will change. If they say the efferent fibers from cerebellum, then your answer will be dentate nucleus. Here the answer should be dentate nucleus, or you can say deep cerebellar nucleus, deep cerebellar nucleus. For this particular question, the efferent from, see this is what I was talking about. Did you notice where the screen went off? It happens if you inadvertently touch it, because see, to avoid that this is required, but it does not work. This thing does not work here. This thing works on my computer here. That is also tragedy. Anyhow, so efferent from cerebellum is from dentate nucleus. I will change the question now. My question now is efferent fiber from cerebellar cortex. Then what will you answer? Then your answer will become Purkinje cell. Once they use the term cortex, then your answer should change to Purkinje cell. So there are 2 statements. Efferent fibers from cerebellum arise from, your answer is dentate nucleus or deep cerebellar nucleus. Statement number 2, efferent from cerebellar cortex arise from, your answer will be Purkinje cell. Leave this. This is important because they continuously ask. So as you notice, this is Purkinje cell sending dendrite into outer molecular layer. Purkinje cell sending dendrites into outer molecular layer. This is the outer molecular layer having SV cell, stellate and basket cell. Very few in number, not dense. So outer molecular layer in cerebellar cortex having stellate basket cell, middle Purkinje layer. This arrow mark is for middle Purkinje layer. Arrow mark is middle Purkinje layer. This is all Purkinje cell, Purkinje cell, Purkinje, 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 Purkinje. Inner granular layer. This is inner granular layer where you have GG cell, granule and Golgi. So granule and Golgi, inner granular layer, and it is very dense. See, lot of nuclei. So it is quite dense as compared with the outer molecular layer. So inner granular layer you have granule cell and the Golgi cell. So just for the purpose of identification, and if you look at this, this is white matter which is quite deep. In cerebellar cortex the cortex outside is gray matter, means neuron bodies. Deeper is white matter. In the cerebellar cortex, deeper will be white matter, and in that white matter you will have some nuclei like dentate nucleus. That is why they are called deep cerebellar nuclei. In that white matter also you will have some nuclei, which we just saw here in this diagram. You can appreciate that first of all, this is cerebellar cortex. You will have 3 layers and 5 cells. The stellate baskets, Purkinje, the GG cell. In the periphery, if you go deeper, there will be white matter, and in that white matter there will be some nuclei, and they are called deep cerebellar nuclei like dentate nucleus. So, outside is gray matter, inside is white matter. In that white matter there is some gray matter, and that gray matter is deep cerebellar nuclei. So, the point was, if somebody asks you what is the output from cerebellar cortex, then your answer is Purkinje. But if somebody asks you what is the output from cerebellum, then your answer is dentate nucleus or deep cerebellar nucleus. So, output from cerebellar cortex, answer is Purkinje. Output from cerebellum is deep cerebellar nucleus like dentate nucleus. 2 questions with 2 different answers. Okay. This is one question which is asking lesion of the rounded elevation on the dorsal side of lower pons. What are you talking about? Can you write in the chat? Can you write in the chat? What are we talking about? Lesion of the rounded elevation on the dorsal side of lower pons. Dorsal side of lower pons. You are actually talking, yes, good. Vishal? Yes, facial colliculus. Facial colliculus. So, facial muscles, right. It is rounded elevation, that is facial colliculus, and the muscles will be facial muscles. Question has come on rhizorius. So, there is a question, and your answer was rhizorius will be paralyzed. Now, once you know the answer facial muscles, you can just have a look here. These are the questions which type of questions which are appearing. So, as you notice, you are looking at the dorsal side of lower pons. If you see, this is superior colliculus, this is inferior colliculus in the midbrain. This is the pontomedullary junction, pons above, medulla below, pontomedullary junction. This is midbrain and pons junction. So, superior colliculus, inferior colliculus, midbrain. This is pons, this is medulla, this is pontomedullary junction. You are looking from the dorsal side, you have removed cerebellum. This is a part of cerebellum which is evident, but you have removed the cerebellum from the roof of fourth ventricle, from the roof of fourth ventricle. So, this is diamond shaped fourth ventricle. This is diamond shaped fourth ventricle filled with CSF. This is diamond shaped fourth ventricle filled with CSF, cannot be seen until you remove the cerebellum from the roof of the fourth ventricle to look at the floor of fourth ventricle. And when you look at the floor of fourth ventricle, you see the rounded elevation, and that rounded elevation is facial colliculus. That is facial colliculus. So, you are looking at the arrow mark which is rounded elevation at the floor of the fourth ventricle on the dorsum of the lower pons. There is upper pons, there is lower pons. So, on the dorsum of the lower pons, facial colliculus, if compromised, facial colliculus is produced by axons of facial nerve, and if the facial nerve is compromised, muscles of facial expression will be compromised. muscle of facial expression will be compromised. But if the lesion is deeper, if the lesion is deeper, deep to facial colliculus, you also have what is called as the LR6 nucleus, lateral rectus supplied by 6th nerve nucleus, abducens nucleus. So, first muscle to paralyze will be muscles of facial expression like rhizorius, and second muscle to get compromised is lateral rectus supplied by 6th nerve, abducens nerve. Why? Because deep to facial colliculus you have abducens nucleus that also might get involved, and that will compromise lateral rectus. Now, berry aneurysm at the anterior communicating artery. Berry aneurysm at the anterior communicating artery origin leads to which kind of hemianopia? Could you give the answer in the chat? Berry aneurysm at the anterior communicating artery aneurysm. You know, anterior communicating artery will be communicating the two anterior cerebral arteries. An anterior cerebral artery and anterior communicating artery, which is connecting the two, both of them supply fornix, and they also supply rostrum part of corpus callosum. These are questions, corpus callosum, rostrum part. So, anterior cerebral artery connected by anterior communicating artery, these arteries supply fornix. I already told you there will be amnesia syndrome if it is compromised, and it is also supplying rostrum of corpus callosum. We will see a diagram. But here, which kind of anopia? Actually, it will compress the optic chiasma. As it compresses the optic chiasma, the temporal vision which crosses in optic chiasma will be compromised. Temporal peripheral vision. So, if the temporal peripheral vision is compromised because optic chiasma is compromised, you will have tunnel vision or what is called as bitemporal hemianopia. So, there will be bitemporal hemianopia. Let us look at the diagram also. You see, this will be the problem. You are looking from the superior view. This is right eye, this is left eye. This is right eye, this is left eye, the right eye and left eye, looking from superior view. My point is the temporal vision cross in the optic chiasma. Temporal vision cross in the optic chiasma here. So, if I have a problem here at the optic chiasma, the temporal or peripheral vision will be compromised, and there will be blindness in the temporal vision, which is called bitemporal hemianopia or tunnel vision. This patient having a problem with optic chiasma will not be able to see what is in the periphery. He can see only something which is nasal or tunnel vision. Now, on the other hand, what is the problem if I have injury of optic nerve on the left side? If I have injury of optic nerve on the left side, then left eye will be blind. Lesion of optic nerve on left side, left eye is blind. And what if I have a lesion in the optic chiasma? Then temporal vision is gone on both the eyes, bitemporal hemianopia, which we just discussed, anterior communicating artery aneurysm. What if I have a lesion in the optic tract, left side? If you have lesion in the optic tract on the left side, contralateral homonymous hemianopia. And what do you mean by contralateral homonymous hemianopia? It means wherever the lesion is, say left lesion in the optic tract, problem will be on the right side. Right half of each eye will be blind. The right half of each eye will be blind. The right half of each eye will be blind. This is binocular vision, and right half of each eye is blind. This person cannot see what is on the right side of his body. If there is a left-sided optic tract lesion, contralateral homonymous hemianopia, means right half of each eye is blind, means right side vision is gone. This patient cannot see what is on the right side of his body. Say I have a lesion on my left optic tract. I am in a class. In the class, I cannot see students sitting on the right side rows. I can see only students sitting on the left side. A lesion on the left side, contralateral homonymous hemianopia. I cannot see the students sitting on the right half of each eye is blind. Right-sided vision is gone. And what if I have a problem in the occipital cortex? If a problem in occipital cortex, same problem, but there will be a central vision sparing. Means again it is contralateral homonymous hemianopia, but with macular sparing. And why macular sparing? You know, if there is a lesion in the occipital cortex of left side, again the right half of each eye is blind, but with macular sparing, because these lesions may happen due to block in posterior cerebral artery. And even if posterior cerebral artery was blocked, the middle cerebral artery supplies some part of occipital cortex concerned with central vision. So maybe it was a lesion of posterior cerebral artery compromising occipital cortex, resulting in contralateral homonymous hemianopia, but central vision is still working, macular sparing, because some part of brain is still surviving, because that part of brain is additionally supplied by middle cerebral artery. So macular sparing. Difference between these two lesions is, in this lesion the central vision is still working, but they are similar in the fashion that both of them are contralateral homonymous hemianopia. Okay, so as we were asking for this question, you already know the answer should be bitemporal hemianopia. This will be the same answer if you had a case of pituitary tumor, because pituitary tumor is also midline tumor affecting optic chiasma. Pituitary tumor is also a midline tumor affecting optic chiasma, so it will present with bitemporal hemianopia or tunnel vision. Okay, what about this question? This is one of the latest question which has come, and it is asking injury to the lateral part of dorsal column at the cervical, conscious proprioception, ipsilateral. See, first of all, it is telling dorsal column. Dorsal column where? In the spinal cord, in the cervical region, the lateral part. What do you mean by lateral part of dorsal column? Lateral part of dorsal column has two parts, lateral and medial, fasciculus cuneatus, fasciculus gracilis. So who is running lateral? Fasciculus cuneatus, because you are in the cervical region. In cervical region of spinal cord, you will have fasciculus cuneatus. Conscious proprioception, that I know because dorsal column carry some sensation. One of that is conscious proprioception, position sense of upper limb, cuneatus, lower limb, then gracilis. So ipsilateral what? Ipsilateral, whatever the cuneatus carry. Yeah, what does it carry? Body above diaphragm. Body above diaphragm means could be ipsilateral upper limb or thorax. Upper limb or thorax. Upper limb is a better answer. So it could be upper limb or thorax, but ipsilateral. It will become more evident when you look at this. So this was the problem. Problem is that there is this cervical spinal cord, and this is the midline of the body. That is left side, this is right side. In the spinal cord, dorsal column, there is a medial portion which is fasciculus gracilis, bringing information from body below diaphragm, for example lower limb. Body below diaphragm, for example lower limb, information is here. But body above diaphragm, that is thorax and upper limb, this information is carried by fasciculus cuneatus, and fasciculus cuneatus runs ipsilaterally. This blue color is fasciculus cuneatus. So question was, if there is a right sided lesion in the lateral part of dorsal column, that is not the fasciculus gracilis involved, but fasciculus cuneatus involved, there will be loss of conscious proprioception. The dorsal column actually carries, it is fasciculus cuneatus is a lateral part of dorsal column. Not only it carries conscious proprioception, it carries a lot of other sensations also, but will be lost where? Body above diaphragm. Body above diaphragm means could be thorax or upper limb. Upper limb is a better answer. If you have both the options, then upper limb will be better answer. So I hope you understood. In this question, your answer is better. You take ipsilateral upper limb. This question is asking about fasciculus cuneatus in the dorsal column spinal cord in the cervical region, because you don't have fasciculus cuneatus in the lumbar region. Lumbar region you don't have fasciculus cuneatus. Fasciculus cuneatus has information coming from body above diaphragm. So it must be above diaphragm information. That is why cervical spinal cord. It is not lumbar spinal cord. Lumbar spinal cord will not have fasciculus cuneatus. It will have only fasciculus gracilis. So I hope you got the point what the examiner is trying to ask here. Then what about this? Medial lemniscus is the continuation of yeah, it can be unconscious also, but unconscious will be affected if the spinocerebellar tract is involved. Unconscious information will be compromised if the spinocerebellar tract is involved, and spinocerebellar tract is not running in the dorsal column. So you just say conscious proprioception. Dark Knight 08 means if you want to talk about unconscious proprioception, then the lesion should be here. Let me show the lesion. You will be then talking about dorsal and ventral spinocerebellar tract. They run here, not there. So if there is a lesion of dorsal spinocerebellar tract, like I told you, position of lower limb carried by same sided spinocerebellar tract. So position of lower limb, unconscious proprioception, position of lower limb, unconscious proprioception will be carried by dorsal spinocerebellar tract. If it is damaged here, if there was ischemia here, then unconscious proprioception will be compromised. But if there is a damage here, then conscious proprioception will be compromised, because this information goes to conscious level, cerebrum, conscious, and this information goes to cerebellum, which is not conscious, it is unconscious. Cerebellum is unconscious and cerebrum is conscious. So dorsal column carry conscious proprioception to cerebrum, that is why conscious, and spinocerebellar tract reaches the cerebellum, that is why unconscious proprioception. So there is a difference. This lesion ipsilateral, unconscious proprioception will be compromised. I hope you understood. And so medial lemniscus is continuation of. Medial lemniscus is second order neuron, and it is just the continuation of dorsal column. As the dorsal column reaches the brainstem, second order neuron will cross and continue as medial lemniscus. So medial lemniscus is second order, dorsal column is first order. Information, like we just said, they will be carrying conscious proprioception. So conscious proprioception was first carried by dorsal column, and then it will be switching over to medial lemniscus. It will become more important, more evident when you look at this. So as we are talking about, say you are talking about proprioception from upper limb, just now we discussed. So proprioception from upper limb is entering the spinal cord, running ipsilaterally, as fasciculus cuneatus in dorsal column. So, upper limb proprioception, which is conscious proprioception, is running ipsilaterally in the spinal cord in fasciculus cuneatus in the dorsal column and reaches the medulla oblongata. At the medulla oblongata, second order neuron will start and cross the midline and go to the thalamus. That is called as medial lemniscus. That is medial lemniscus, second order neuron. Let me zoom this a bit. First order neuron is fasciculus cuneatus in the dorsal column, carrying conscious proprioception till medulla. In medulla there will be a synapsis, second order neuron will cross the midline and start running as medial lemniscus. Lemniscus is nothing but bundle of axons in brainstem. Lemniscus is bundle of axons in brainstem. If it is medial or lateral, lateral lemniscus auditory pathway, medial lemniscus for carrying the sensation of dorsal column like conscious proprioception. So, medial lemniscus carry conscious proprioception, lateral lemniscus carry auditory pathway in the brainstem. Now, if this is second order neuron, it is running contralateral. Where is it going? It is going to thalamus, VPL nucleus of thalamus, ventro-postero-lateral nucleus of thalamus, VPL, ventro-posterolateral nucleus of thalamus, and from there you will notice this information because it is conscious, it must go to cerebrum. So, from there you can see for yourself this information now will be reaching the cerebrum, That is why you say it is parietal sensory cortex, area number 1 to 3. Parietal sensory cortex, area number 1 to 3, Broadman number, post-central gyrus basically. So, from the thalamus it will go to parietal sensory cortex, post-central gyrus, area number 1 to 3. And since the information reaches the conscious level, cerebrum, that is why you are calling it as conscious proprioception. If it was unconscious, it will stop at the level of cerebellum. So, your question was here, medial lemniscus is continuation of, your answer is dorsal column. Dorsal column continue as medial lemniscus. Dorsal column is first order neuron. After decussation, it becomes medial lemniscus, then decussates, and this is second order neuron. Now, you already know the answer to this question. Tell me. No, you cannot say, see, dark night 08, dorsal column and anterior spinal. If you say, okay, I agree. If you write like that, you must have read Vishram Singh neuroanatomy, I believe. Fine, no problem. Dark night 08, dorsal column and anterior spinal thalamic tract is running in medial lemniscus is acceptable, because it is the lateral spinal thalamic tract which run in the lateral, in the spinal lemniscus. So, if you say dorsal column and anterior spinal thalamic tract is running in medial lemniscus, agree, but you should also know lateral spinal thalamic tract will be running in the spinal lemniscus. So, there are 4 lemnisci, medial lemniscus, then it is trigeminal lemniscus, then it is spinal lemniscus, and then it is lateral lemniscus. 4 lemnisci are there, MTSL, medial lemniscus medial, then the trigeminal lemniscus, then spinal lemniscus, and then the lateral lemniscus in the brainstem. Agree? Yes, Shilpi, correct. So, I will show a diagram and then it will become still better. Anterior cerebral artery and anterior communicating artery. Anterior communicating artery basically connect the 2 anterior cerebral arteries. Now, here you see I have written rostrum of corpus callosum. Earlier I have written fornix, but the supply is same, and it will become more evident when I show this diagram. say, let us assume there is an internal carotid artery, which is giving anterior cerebral artery, anterior cerebral artery. So, internal carotid artery giving anterior cerebral artery, and anterior cerebral artery is the major artery to supply medial part of cerebrum, though we understand that there will be two vertebral arteries forming the basilar artery, forming the two posterior cerebral arteries also. I will repeat, there will be two vertebral arteries forming the basilar artery, forming the two posterior cerebral artery, right and left of course. So, internal carotid artery will give us two anterior cerebral arteries, right and left, and this is anterior cerebral artery. Major part on the medial cerebrum is supplied by anterior cerebral artery. Anterior cerebral artery is the major artery to supply medial side of cerebrum, or whatever you see here, most of it is supplied by anterior cerebral, but partly it is supplied by posterior cerebral. So, two vertebral forming basilar, this is vertebro-basilar artery forming posterior cerebral is also shown. Now, why I have shown this? Though understand, this is the rostrum of the corpus callosum, this is the genu of corpus callosum, this is the body, and that is the splenium. So, if somebody is asking you splenium of corpus callosum is supplied by, then your answer will be posterior cerebral artery. That is the point. The rostrum or the genu or the body of corpus callosum is supplied by anterior cerebral artery, whereas splenium of corpus callosum will be supplied by posterior cerebral artery, which itself is a branch of vertebro-basilar system, which is more posterior. So, posterior. Where is fornix? Fornix you can see here, this is fornix. So, if this is the fornix, it is understood that most of the fornix will be supplied by anterior cerebral artery, and not only anterior cerebral artery, as you understand, the internal carotid artery will give two anterior cerebral arteries, it will be giving two anterior cerebral arteries, and these two anterior cerebral arteries, how do they connect with each other? They are connecting with each other with the help of anterior communicating artery. So, I will repeat again, internal carotid artery, one on right and left side, will give anterior cerebral artery, one on right and left side. The two anterior cerebral arteries are connected to each other by anterior communicating arteries. Point is, medial cerebrum is majorly supplied by anterior cerebral artery, no issue. It also supplies most of the corpus callosum, including rostrum, genu, body. It also supplies most of the fornix, but the second artery to supply fornix and corpus callosum is anterior communicating artery. These questions have come recently, and maybe the examiner, whoever the examiner is, they belong to AIIMS mostly. They keep doing some PhD topics. His PhD topics would have been amnesia syndrome, secondary to ischemia in the fornix, but that is his PhD topic, not ours. Now, maybe it is his PhD topic, not ours, but he is all granted the permission to ask the question to us, and we suffer the consequences. This information, if you search in Gray's Anatomy, it is scattered. It is there, but it is scattered. So, you collect it and make a consensus, and you are not sure also. You are not sure. It is just, okay, I found something, so this is the answer, but I am not sure about the answer, but this is the best I can do. It is me speaking basically. So, questions have come, my job is to give you the answer, and I should not give wrong information also. Have been teaching anatomy for last 20 years, have tried my best that do not give wrong information. It is better you do not give information rather than giving wrong information. It is Hippocratic oath, do no harm. फायदा बात की बात है, नुकसान मत करो. तो पढ़ाते हुए गलत बात मत बोलो, छुपा लो, नहीं पता नहीं पता, सामने बोल दो नहीं, I don't know, but don't speak nonsense. So, if I don't speak nonsense, somebody is asking nonsense, then what should I do? Then you do whatever is possible. This is what I can show you a diagram also for that. Those diagrams are not available in Gray's Anatomy. I have those diagrams, but it is useless to show such diagrams to you people because you are already burdened, and like one student told, एक ही question में सारा confidence उड़ गया. That is not the purpose of any teacher to take your confidence down. It is, then my job is, it is useless. Myself standing here is useless. I should help you, not discourage you. So, see, the way I told you is very simple. I told you just this. Just remember this. This will be enough. You can just mug it up. Even if you do not understand, just mug it up. Read 10 times before exam and you will answer it correctly. That is the best I can tell you. Anterior cerebral artery and anterocommunicating artery supply the rostrum part of corpus callosum. Not only rostrum, most of the corpus callosum except splenium, because splenium part of corpus callosum is supplied by posterior. It is posterior, so posterior cerebral artery. And most of the fornix, these two arteries. And they are questions. Already they have come. I do not teach you anything which examiner has not asked or is about to ask. I do not want to waste your time at all. That should not be done if you are a true professional, and still I am wasting your time. Sometimes you cannot help it. Okay, what do you think? Hemorrhage occurs in rupture of superior cerebral vein. Superior cerebral vein is bridging vein. Now, can I get the answer? How to memorize blood supply of internal capsule? Watch my videos on YouTube, it will help. Yes, very good. SDH. SDH, subdural hemorrhage. I will ask you the next question then. This is subdural hemorrhage, yes. I will ask you the next question. Internal capsule, I think I have some videos on YouTube, just watch them. You can just go to YouTube, or you can go to Google actually. Google, you write Rajesh Kaushal, internal capsule arteries, it will come. Some YouTube video will come. So, recently asked question, very frequently asked question, so I will ask you. See, just now you have answered subdural hemorrhage, which is, crosses the suture line and is convexo-concave, like somebody will say banana shape. So, subdural hemorrhage is crossing the suture line and is convexo-concave, banana shape, bleed of bridging veins like superior cerebral veins, one thing. Usually not an emergency, usually not an emergency. On the other hand, if you say extradural or epidural hemorrhage, extradural epidural hemorrhage, it is always an emergency because it is arterial bleed. Which artery bleeds is anterior division of middle meningeal artery. So extradural or epidural hemorrhage is mostly an emergency because it is arterial bleed. Arteries keep bleeding until you take care of that, and it is anterior division of middle meningeal artery bleeding, usually deep to pterion, which is weak place at the skull, pterion fracture, bleed of anterior division middle meningeal artery. So that is the source of bleed. What about this? It is biconvex, as you understand, biconvex shadow, and will be bright, whitish or bright, because acute, mostly it is acute. This could be dark because could be chronic, because I told they don't come immediately, so chronic, so dark. Subdural hemorrhages bleed, then they come, so chronic, darker color in your CT scan, but these are whitish, bright because acutely presenting, though there can be overlapping. Okay, what about the intraparenchymal hemorrhage, intraparenchymal, like putamen or lentiform nucleus hemorrhage? So putamen or lentiform nucleus hemorrhage could be hypertensive patient, and it could be lenticular-striate branches of middle meningeal artery, microaneurysm, which is Charcot-Bouchard microaneurysm rupture. I will repeat, this is intraparenchymal hemorrhage, could be putamen hemorrhage or lenticular nucleus hemorrhage, basal ganglia. It can happen in hypertensive patients. Hypertensive patients can have microaneurysms, Charcot-Bouchard microaneurysm rupture. Branches, in the branches of lenticular-striate branches. Lenticular-striate is what? Lenticular nucleus, striate nucleus, basal ganglia. To supply the basal ganglia, middle meningeal artery gave branches. So middle meningeal artery which gave branches to the lenticular-striate area, lenticular-striate branches, they can have Charcot-Bouchard microaneurysm and they bleed. These are questions which have come recently. Plus, what about the subarachnoid hemorrhage, where you can have hemorrhage in the subarachnoid space or in the ventricles also. So inside the ventricles or in the subarachnoid space, what was bleeding? Could be a rupture of Barry aneurysm, which is also called as saccular aneurysm. So bleed of saccular or Barry aneurysm. This mostly in the circle of Willis, mostly anterior circulation like anterior communicating artery. So blood in the subarachnoid space or blood inside the ventricles, which is subarachnoid hemorrhage. Subarachnoid hemorrhage can be happening due to rupture of Barry aneurysm or saccular aneurysm, same name. In the circle of Willis, some bleed was there. For example, anterior communicating artery, saccular aneurysm bleeds, and young adults thunderclap headache. All those things are there. Typical presentations may not be there, but just remember like that. So just some information which you should have because recently coming questions, that is neuroanatomy. Now moving on to head neck. We started at 5. We started at 5 and it is 7:50 and we are not even halfway. That is a tragedy with me. One-liners become 10-liners. And your exam is very nearby. I should not be taking too much of your time. I am not a person who can do things quickly. I thought we should stop at 7. We started at 5, I believe. Oh God. What to do? See, I told you in the beginning of the class, you should be spending more time with yourself in self-study, revising quickly. I am not the person who can make you revise quickly, and though I tried, and it's better I should stop here, though I have some content left with me. I cannot even request Prepladder people to give me a second session, because exam is just and the day you have this INI-CET exam, I will be in Bangalore Medical College, my MBBS college. So, we are going there for 2 days. I think I should stop here. I lose track of time, that is a problem. But I am hopeful whatever we could cover, that will be helping you a lot in the coming exam, and to make you better physician, better surgeon, better human. All the best. Take care, please.